who have worked to pull this together, so specifically Oriane and Robert. But then I also wanted to thank the organizations who have pulled this agenda together and pulled this meeting together. So that includes CHAI, CRS, UNICEF, the Gates Foundation, Malaria Consortium. So thank you very much to those partners. And then obviously, as well as we did in the earlier meeting, thanking you, the individuals that have chosen to participate in the room and online. And while many of us are the same as participated in the MP partners meeting, there are some new partners here. So what I wanted to do was just ask if we could pass the microphone around. I'm not sure if... there's Miko. So if we could pass the microphone around again, if you can just quickly stand, introduce yourself, your title and the country you're coming from, or the country you're supporting.
Good morning. My name is George Gakambi. I'm from Kenya. I'm from Alert International. I'm a stakeholder in the malaria programs. Thank you.
Bonjour tout le monde, Irsou, équipe technique au sein du Programme national de lutte contre le paludisme de Madagascar.
Bonjour à tous, c'est Joëlson de Madagascar. Je suis un technicien au sein de la lutte antivectorielle.
Yeah, good morning. I'm Matul Temtiang from South Sudan, Minister of Health, in charge of Health Information System. Thanks.
Philip Brewer, National Malaria Control Program, Sierra Leone.
Good morning. I'm Anita Kamara, Malaria Control Program, Sierra Leone.
Good morning, everyone. I'm Musa Silakanu. I'm Head of Malaria Surveillance Monitoring Evaluation, National Malaria Control Program, Sierra Leone.
Good morning, everyone. I'm Tawani Kumbalahai. I'm the Deputy Program Manager, National Malaria Control Program, Sierra Leone.
Good morning, everyone. I'm Mona Lakon from WHO Headquarters, Geneva, from GI Center for Health.
Hello and good morning. My name is Chris Warren from the United States. I am an AMP consultant working on the development of guidelines for the scanning and data capture of GS1-based data carriers.
Good morning, everyone. My name is John Bastow from France, and I work with a bednet manufacturer, GDM. Thank you.
My name is Mike Makori from that organization. We are dealing with malaria in Kenya.
Good morning, everyone. My name is Katis Chalwa from the Zambia National Malaria Elimination Program.
Hello, everyone. My name is Salim Fak Salim. I'm from Zanzibar. I'm working with Zanzibar Malaria Elimination Program.
People call me Marcel Lama. I am at the malaria program in Central African Republic.
Moi, c'est Patrick Bongo. Je viens de la République centrafricaine. Je travaille avec la Croix-Rouge française dans le cadre de la subvention Fonds mondial.
Bonjour à tous. Good morning. I'm Stephen Poyer. I'm Senior Technical Advisor for Tropical Health based in the UK.
Good morning. I'm Mathieu Aoui, the Deputy Chief of Party for the Global Fund Grants in Central African Republic.
Good morning. My name is Babacar Ngom. I'm based in Dakar, Senegal. I'm the Digital Data System Lead for Neglected Tropical Disease at Site Savers. Thank you.
Good morning, everyone. My name is Olukado Dufua. I'm with the Fakara Health Institute, Tanzania.
Good morning, everyone. My name is Alpha Moyan from Mozambique. I'm Digitalization Focal Point, NMCP.
Bon dia. My name is Mariana da Silva from NMCP Mozambique Digital Platforms. Thank you.
Good morning, bonjour. I'm Hannah Bilak. I'm Director of Programs at PATH, and I'm also the RBM CRSPC co-chair.
Good morning. I'm Brad Didier with the Clinton Health Access Initiative. Thank you.
Good morning. My name is Lauren Tice, and I'm a Digital Health Technical Advisor for Clinton Health Access Initiative as well.
Good
morning. My name is Stefanos Berusharge. I'm from the Global Fund. I work for the Programmatic Monitoring Department as Senior Specialist.
Bonjour à tous. Je suis Eric Chassa. Je travaille pour Imaword Health. Je suis basé à Kinshasa, République démocratique du Congo.
Bonjour à tous. Je suis Marius Ngoyi du Programme national de lutte contre le paludisme de la République démocratique du Congo, DRC, basé à Kinshasa.
Good morning. My name is Ochai. I'm a digital health consultant, and I also work with Red Rose in Nigeria.
Good morning, everyone. My name is Fatou Sow. I work for Dimagi, and I support deployment for ComCare in Western Central Africa.
Good morning. My name is Mary Rochlow. I'm Director of Technology at Dimagi.
Hi, everyone. Anita Kruger, Director for Business Development, Dimagi.
Hi, I'm Sophia Kaufman. I'm with the Clinton Health Access Initiative based in Kigali, Rwanda.
Good morning, everyone. I'm Amina Bagana, Informatics Lead with Biosystems. I'm based in Abuja, Nigeria.
Hi, morning, everyone. I'm Neil Gutka, Senior Operations Manager at the Against Malaria Foundation based here in Nairobi.
Hi, good morning, everyone. My name is Xingchen Li, and I'm now an intern at IFRC and AMP team. And also, I'm a student from Shanghai Jiao Tong University School of Medicine from China, and also from China CDC. Thank you.
Good morning, everyone. John Cox from the Gates Foundation based in Seattle.
Hello, everyone. Good morning. I'm Sid Rupani from the Global Fund Supply Chain Team.
Thank you, Sid. Hi, everyone. Good morning. This is Satish Chaudhary from the Gates Foundation Malaria Team based in Seattle. Thank you.
Hello, everyone. My name is Ola Hariola. I work with UNICEF's Digital Health and Information Systems team.
Bonjour, moi c'est Dr Clément Kerain Zoumé, je suis du PNUD au Tchad.
Bonjour à tous, je suis Dr Diar Moussa Lessakha, coordinateur du PNLP Tchad.
Morning, everybody. I'm Marcy. I'm the lead for malaria programs at the IFRC, and I'm the lead for AMP.
Good morning, everyone. Molly Robertson. I'm the co-chair of the Surveillance Monitoring and Evaluation Working Group.
Bonjour à tous, je suis Ole Bagamla, je travaille au PNUD Tchad.
Good morning, everyone. I'm Dr. ACN. I work with Malaria Consortium as a Digital Health Manager. Thank you.
Good morning, everyone. My name is Nick Banks. I'm also part of the Digital Health team for Malaria Consortium based in the UK.
Good morning, everyone. My name is Norman Aweno. For Malaria Consortium in South Sudan as a Monitoring and Evaluation Coordinator.
Bonjour à tous, je m'appelle Neos Habib, je suis de la Guinée-Bissau, je travaille comme Monitoring and Evaluation Analyst au PNUD.
Bonjour, je m'appelle Jean-Noir Biague, coordinateur de PNLP Guinée-Bissau.
Bonjour à tous, je m'appelle Mohamed Oulamed, je suis chargé de suivi et évaluation PNLP Guinée-Bissau.
Good morning, everyone. My name is Dominique Guinaud. I'm the director of the Global Fund Support Unit at CRS, based in Geneva.
Bonjour à tous, médecin colonel Aïsta Kone, directrice programme PALU Mali.
Bonjour à tous, moi c'est Boubacar Sidik Maïga, je travaille pour CRS au Mali.
Hello, everybody. My name is Kuwait Manuel with Crosscut. Uh-oh. Sorry to turn out the lights. Hello.
Good morning. My name is Abdul Razak Musa. I'm with Malaria Consortium based in Mozambique as a digital health specialist. Thank you.
Hello, Paul Mwangi, Inter-Urban Network Africa, Kenya.
Morning, I'm Gitanya Peter from NMCP Tanzania.
Morning, everyone. My name is Elijah Geshinga.
I work with Medic, based in Kenya, and we are the stewards of the Community Health Toolkit. I hope you guys have heard of it.
Good morning, everyone. I'm Robert Opoku. I work with IFRC and also MP.
I'm Laure Pontis for Blue Square.
Good morning, everyone. I'm Jacinta Nyambura from Blue Square.
Bonjour à tous, je suis Jules de Mauricel Matondo, le chargé du suivi et évaluation au programme national de lutte contre le paludisme en République du Congo. Merci.
Bonjour tout le monde, je suis Nyarabi Koutagras au programme national de lutte contre le paludisme Congo.
Good morning, everyone. I'm Roch Aikpon. I'm the Deputy Coordinator of NMCP Benin.
Bonjour tout le monde, je suis Rodrigo, conseiller technique du ministre de la Santé du Bénin aux soins de santé primaires et président du comité de pilotage de la nouvelle politique nationale de santé communautaire. Merci.
Bonjour à tous, je suis Sebastiano Dossiovo, le directeur des systèmes d'information au ministère de la Santé du Bénin.
Good morning, everyone. My name is Dr. Yata Saki Wapo. I work for the National Malaria Control Program as Deputy Manager in Liberia.
Okay, good morning. I'm Joseph Alade. I'm the Program Digital Lead for NMCP Liberia.
Bonjour, I'm Cedric from Results in Health based in the Netherlands.
Bonjour, Giovanni Dusabi, consultant AMP.
Bonjour à tous, Fred Vami, consultant AMP.
Bonjour à tous, good morning. I'm Ali Khalil from Blue Square.
Good morning, I'm Geronimo Zandamela. I work for MP. I'm based in Maputo, Mozambique.
Good morning, everyone. My name is Amira Ipin, and I'm a consultant with IFRC.
Bonjour, je m'appelle Valence Nimbona. Je travaille pour l'AMP comme consultant.
Good morning, my name is Christine Waya from Kenya National Malaria Control Program.
Good morning, everyone. I'm Andrew Glover. I'm a research associate at Imperial College London in the UK.
Morning, everyone. I'm Eleanor Sternberg. I'm the research manager at Tropical Health, and I'm based in the UK.
Hello, everyone. This is Neeta Tyagi, Director Partnerships from EGA Foundation, which is based in Bangalore, India. Thank you.
Good morning, everyone. My name is Edson Zandamela. I'm a consultant with the AMP based in Mozambique. Thank you.
Good morning, everyone. My name is Hervé Muneza. I work from EGA Foundation, and I'm based in Mozambique.
Good morning, everyone. I'm Gedeon Banswe, working for the GIS Center WHO. Thank you.
Bonjour à tous, c'est Madame Espérance Mbia, chef de division prévention multiple au PNLP Congo, RDC Congo. Merci.
Good, well thank you very much and welcome everyone once again. Sorry, we have someone in the back, a very important person in the back who's going to stand up and introduce himself.
Bonjour à tous, Oriane Béraud de l'AMP.
Great. Welcome, everyone.
Okay. I'm Samuel Chumando, NMEP Ghana.
Welcome. And the team, I think there's more from Ghana. Do you want to just quickly introduce yourselves, name, title, and where you're from? And then we'll get started.
Christian Ataobe, NMEP Ghana.
Justice Wachi Adam, NMEP Ghana.
Good morning, everyone. My name is Stephen Karuru from WHO Kenya Country Office. Thank you.
Okay, thanks everyone once again. So just before I hand over to Sid, who's going to give us a keynote welcome, I just wanted to, we're going to have 4 themes in this meeting. So we're going to start today, and Robert's going to lead us through the theme of data for decision making. Then just before lunch, we're going to transition into the theme of outcomes and evidence for digitization. I think a very important session, if you check at the very bottom of today's agenda, we have a session called the Happiest Hour. So at the AMP Partners meeting, we had a reception, but tonight we have a happiest hour. I think in these times of change, a happiest hour is going to be very interesting. So Robert, we look forward to the happiest hour later today. Then tomorrow, we're going to start with outcomes and evidence for digitization. Then we'll transition to governance, ownership, and sustainability. And then the last half of the afternoon tomorrow is a workshop and different learning sessions. So I'm going to now invite Sid Rupani from the Global Fund. And Sid's going to give us a keynote address to start this year's meeting. And the title is Digitization, IT, and Distribution, Shaping the Future Amid Resource Constraints. So over to Sid and welcome.
Hello, good morning everyone. I'm really excited to be here, and I'm honestly honored to be asked to provide some opening remarks. I am relatively new to the world of ITNs. This is only my third AMP meeting, but in the 3 years that I've been part of this world, I have learned a lot from all of you, and I've seen how special this community is. The first AMP meeting I was part of, when they gave the awards, when they gave out the capes, just seeing the joy in the room where people were celebrating the achievements and effort of your colleagues was a moment where I realized that this community was special. And it shows in the results that you've achieved together over the last 2 decades. So thank you all for that. So that was a little bit of what's brought me here. And now let's look at where we are and where we'll need to go in the future. I will refer back to some slides that we saw from the partners meeting. We have entered a phase of accelerated change. If you remember this slide from Mark's closing of the partners meeting, this is what he described as a punctuated equilibrium model, and we are squarely in the middle of one of those red rectangles right now. Right? Resource constraints are real, they are stark, and they are potentially accelerating. And we have no option but to adapt. Like in this case, the snails had no option but to adapt to the ice ages. While we adapt, we don't want to backtrack or lose out on your hard-won gains over the last 2 decades. Right? You have made hard-fought gains on malaria prevention, on ITN coverage of households, and we must retain them. We must do our absolute best to retain and build on that foundation. And so what I'm going to do is say, what have we heard about where we need to get to? What's the direction we'll need to shift to adapt? And then how does digitalization fit into that direction? So what are some of the things we've heard about where we'll need to get to? First, we've heard we need to move from universal coverage to optimal coverage. What does that mean? That means we'll need to prioritize certain geographies, potentially deprioritizing others. We'll need to prioritize certain populations, for example, pregnant women or children under 5. And we'll need to be targeted. Right? That was one of the key messages from the first 2 days. Another way in which we'll need to change is to move from one predominant channel with a smattering of other channels to a truly multi-channel approach. What does that mean? That means scaling up continuous distribution substantially, whether that's through ANC, EPI, schools, or community distribution. That also means keeping in mind the potential of private sector channels or market-based models. And as we look across this multi-channel approach, we've been asked to integrate. If we're talking about campaigns, we need to integrate with other programs running campaigns, whether that's EPI or NTDs. If we're talking about routine, then we need to integrate into the systems of the routine supply chain, whether that's their ELMIS or whatever else they use to manage their routine product distribution. So those are some of the changes in direction, right? Universal to optimal coverage, single to multi-channel, and at the same time, as we're making these changes in direction, this is the where we need to get to, at that same time, we also have to find relentless efficiency because of the resource constraints we're going to face. We'll have to cut through a lot of the complexity and noise we have and find ways to really drive efficiency, whether that means doing micro-planning more efficiently through integration with other programs, building on their data, whether that means more effective supervision targeted only where there's high risk. We can go through many of those levers, but we're being asked, and we must, change direction and also find efficiency at the same time. So now the question is, how does digitalization fit in? Right? This is all the direction we're trying to get to. How does digitalization fit in here? So the question is digitalization an essential enabler of this change in direction and the need to find efficiency? Or is it a nice to have add-on? And we are all at this meeting, hopefully because we believe, and I will try to convince you, that it is an essential enabler. It's really the only way we're going to be able to get to the future we need to. Why is that? Because without granular data, how are you going to target the optimal coverage that you need? How are you going to know that your interventions are working? How are you going to know that your nets are reaching the people who need them and are likely to use them? You need those digital data systems to do that. And you also need them to drive that efficiency at the same time. You need to know where in your system the costs lie, what is disproportionate, where can things be cut without really dramatic impacts to program delivery. And so to do all of that, you need this granular information, and the only way to get that is through digitalization, to continue to build on the information systems you have. So hopefully we agree that digitalization is an essential enabler to get to the future we'll need to get to together, and not a nice-to-have add-on or a luxury. But now let's talk a bit about the how and the what of digitalization. So here's a little schematic, and we can come up with many schematics, but I'll just talk through a few key points on how we can think about what we digitalize and how we digitalize. So first, we need to design. What do I mean by design? We need our vector control strategy to drive what we're digitalizing. So one example might be, what's the share across those different channels I mentioned earlier that I want to use? Which ones are my priorities? Which ones do I want to scale up? And then accordingly, you will digitize those systems. If you want to digitize primarily for campaign improvement, then you'll select the modules you need from a campaign digitization system, whether that's microplanning, registration, supply chain, whatever it might be, payments, the modules you need to achieve the effect you need to drive your design. Right? So first design, then digitize, then a word that I'm not confident is really a word, I may have made it up, but to fit the verb frugalize, right? What do I mean by frugalize? Even in our digital investments, we don't have the luxury of making investments that pay off in the future. We'll have to make really tightly scoped, frugal investments. What are the ways in which digitalization can be frugalized? If you're doing a campaign management tool, can you consider bring your own device? If you're doing trainings, can you consider e-learning or digital trainings? For your warehouses, can you consider digital warehouse inspections? Those are all points that we've heard in the first 2 days, but that's what I mean by frugalize even as you roll out your digitalization. When you look at the tools you're adopting, you will need to look at them on what is really going to be my lowest total cost of ownership, right? Whether that's open source or proprietary software. Really think through what's my total cost of ownership, how am I going to manage this sustainably? So that's what I was trying to convey by frugalize. Then, what's the journey you've taken until here? You have things already to build upon. You're not starting with a blank slate. So within malaria, you might have things to integrate into. You might already have systems, and then even within particular, whether it's ITN, SMC, IRS, you might want to do integration there. But we're not limited to malaria alone. We really need to look across the programs being delivered in your country now because of the needs we have at this moment. This was always true, but it's particularly stark now. If we have registries from EPI programs, why can those not be shared to help with your microplanning? For example, if campaigns are being run for NTDs, why can they not be integrated with malaria? Things like that, right? So the same integration choices at the program level will drive integration choices at the digitalization level. The last one is implement. And when you implement, you'll want to drive that efficiency, but I won't spend much time on that phase. I'll spend more time on that feedback arrow, going back to the design, because that tightened feedback loop is essential. If we think back to what Mark said, for that ice age, right, for that period of accelerated change, which were the creatures that survived? Those that could adapt. How do you adapt? By having rapid feedback loops to learn. You test something, you learn, you adapt your design. Right? So those feedback loops really need to get tight. And that's why I'm saying that arrow is really important to go back. So that was a bit of the of the how and the what of digitalization. And then I'll just close with a collective call for all of us, which is, it seems like we are being asked to do a lot. And we are, right? We're being asked to change direction. We're being asked to find efficiency. We're being asked to do all this rapidly. It is a lot, but it is what we need. And collectively, we must try and do our best to do this lot that we're being asked to do because we can't afford to backtrack on the gains of the past 2 decades. And digitalization is not a luxury, it is your essential enabler for how to get there. So as Marcy put at the end of her talk, improvise, adapt, overcome. Your plans can change, but let's stay true to our vision. Thank you so much.
Thank you very much, Sid. I'd like to invite Robert Opoko, who's going to come up and lead us through our first session. The theme is data for decision making. So welcome, Robert.
Good morning. Good morning. I want to be sure we are all awake and alert. Some of us have been here for 4 days, so I'm going to say it again. Good morning. Great. So for our next session, as Jason said, we will be looking at some examples on data, how we are using data for decision making. I'll call Dorcas Essien from Malaria Consortium Nigeria to join me here. We have another presenter from UNDP. They will do it online. So we have Angela and the team who are with UNDP who join us online. Dorcas, please join me here. So why is Dorcas come? Just maybe a quick question to just give an overview of this particular session. How many of us have used Google Maps before? If you have used Google Maps, let me see your hand. So how many of us have planned how we are going to spend based on our budget before? You plan based on your bank statement or you budget based on the money you have. How many of us have done that before? I see a few hands down. So that means that some of us, we have data but we don't use it, if your hand is down. So typically when you are using a Google map, what it gives you is some data based on your location. In campaigns, we have a lot of data, but sometimes we don't really have people using it. It's just, the data that we have. So for the next session from this morning until lunch, we want to see some of the countries that are going to share with us their experiences on how the data they are collecting, they use it to make decisions, join campaigns, and even after the campaigns, how it informs various decision making. So to start the presentation, I'll call Dorcas to share with us their experience in using the Digit ACM in KB, and how their interactive dashboards and customized reports have helped them with their informed data decision making.
Is this what I use? Hi, good morning, everyone. Okay, so I'll be taking us through our experience with the use of Digit SCM for campaign in KB, precisely SMC campaign. This is just a summary of the slide. We're looking at the background and the context. SMC campaign in KB, Nigeria, using Digit SCM, achievement, challenges and lessons learned, conclusion and recommendation. Okay, I'm Dorcas Essien once again from Malaria Consortium. This is just a brief overview of Malaria Consortium. Malaria Consortium is one of the world's leading non-profit organizations specializing in prevention, control and treatment of malaria and other communicable diseases among vulnerable population. And our mission is to save lives and improve health in Africa and Asia through evidence-based programs. Okay, so SMC is a community-based program. Basically, is a prevention strategy for high burden areas. Basically, we provide anti-malaria medicine during peak transmission period. That is what SMC is all about, and is delivered at the community level. And the strategy is door-to-door to children 3 to 59 months, and is spaced between 28 days apart across 4 to 5 circles. So there are states that do 4 circles, and there are states that do 5 circles. So basically for us, Malaria Consortium, especially for the SMC campaign, we've been using paper-based to implement this across our state, and this has been quite labor-intensive and prone to error. We all know about how that can be, and the turnaround time for access to data for decision-making has been an issue, because especially for us in Nigeria, we do this in quite large scale. I'm talking about quite large population, and so having to aggregate that data after using paper can be quite labor-intensive. But from 2003, Malaria Consortium started integrating technology to support their SMC program implementation. So why we digitize SMC? Greater accountability. Like I mentioned in my previous slide, we've been using paper-based, and we implement SMC in about 9 states in Nigeria, and the population is quite high. And so using paper-based is quite a lot, having to do with the turnaround time, the issues of accountability. So this is part of why we introduced technology, greater accountability, reduced time between data collection, faster tracking of referrals and adverse events, aggregated checklists, and better supervision, improved data storage. Like I said, we use paper, and sometimes those tools and the tools we use for aggregation can get missing, and so it causes a lot of issues as well. Optimization of campaign investments, basically reuse of data, which is what we plan to do. So beyond just using the tool to collect data, we plan to continuously build on the data to ensure that there's improvement in the campaign, and that can also inform decision-making moving forward. Okay, Digit STM in Nigeria. SMC digitization in Nigeria is actually not new. We've used other platforms like Red Rose, DHIS2, and Reveal as previously been used, but Digit STM was introduced in Nigeria in the 4th cycle of SMC in Kebbi State, Nigeria, and we use the bring your own device approach for that part of implementation. This was the first use of digital solution to support SMC in Kebbi State. Kebbi State have been doing SMC, but this was the first time we introduced technology to support SMC implementation. Okay, so the introduction of the tool followed a normal software development process from the requirement gathering up to the deployment. So what that means is that for each stage of the implementation, from the requirements, each stakeholders were properly engaged, because this is something that for that state in particular, this was the first time we're going to be introducing technology into it. So a lot of stakeholders' engagement needed to come into that as well. And also, the aim of doing this, beyond just using it in Kebbi State, was to see how we can scale it up to other states where we'll be implementing SMC. So these are the key components of the digitization using Digit. We digitize the household and child registration, the SPAC distribution, recording of adverse events and referrals, stock management, supervision, and report for data review. Yeah, so beyond just implementing the tool, using the tool to support the program implementation during that time, we did a post-evaluation of the tool. Majorly, we wanted to be sure how the users, of course, we did a user acceptance testing as part of the product lifecycle. We ensured that we got user feedback before moving on into the actual deployment of the tool, but after which there was also a post-evaluation to look at the overall user satisfaction across different areas, data use, data use, user experience, the system performance, the security, and all of that. But basically, this presentation is going to be looking at that evaluation, but it's also going to be looking at the programmatic learning as well. So we're not just focused on the evaluation. Okay, so this is just the key highlights and the results. We trained about 7,200 application users across the 21 local governments in the state. So this was statewide, and this is the first implementation of Digit SCM using the bring your own device approach globally. And as I mentioned before, we did a user acceptance testing because we needed to ensure that whatever it is we're bringing, because this was their first time, we get their feedback before we're able to move forward, and the user feedback was quite good as well. So basically, users embrace fully digital approach by day 2. Yes, by day 1, there was a bit of struggle with the two different users being comfortable with their workflows, but then we had a cross-sectional technical help desk where people can report issues, and we can provide support on the spot. So there were people on the field who can provide first-level support. If they cannot do that, they can scale it up, and it goes forward as well. And so what we know is that timely and available data report at all levels for reporting and informed decision-making was very important because of this particular implementation. So there was data even for the help desk. Users can easily report whatever issues they were for them. And the campaign reached over 1.3 million children in KB State, achieved 91.1% administrative coverage. And so the shift to digital will improve reporting accuracy, which reduced our coverage of SMC distribution from usually we will have above 100 in our coverage reporting, but we noticed that by the introduction of digital tool, from Circle 1 to Circle 4, we have reporting rate of over 100%. So we had something more accurate, we think so, which is like 91% in the 4th cycle. So that was a drastic drop from what we usually see across other circles. And just to highlight that the percentage of community distributors, health workers, and all of that, as part of the evaluation, said that the tool helped them in reporting accuracy and the speed of drug distribution and the accuracy of the records that they collect. Usually they will use paper as they use paper to document all the different tools. They go with a lot of tools, and it could be quite cumbersome for them to fill out all of those tools. But in the evaluation, they recorded that it allowed them, it helped them. There was speed in the way they distributed the drugs, and also in the accuracy of the records as well. So this is another aspect of the use of data I want to highlight. The diagram there is just looking at the flow of data from the lowest level, which is the community drug distributors. They're the ones that record the drug distribution on the app. So they sync their data to the server, and each people at each level can access that data, starting from the LGA, their supervisors, the LGA, and the state level. And so this is just to highlight the way data was being used in the state level. So when they sync the data, the LGA level are able to access the data through the dashboard and are able to review the different KPIs on the dashboard and provide near real-time support to them. And so by the end of the campaign, changes and improvements are made to the data before it gets to the state level. So also at the state level, there is also the evening review meeting that happens, as we can see in the middle picture there. That is the situation room in the state, where at the end of the campaign every day, all the state malaria focal persons would meet to review the data. So this activity usually was done manually. So people would just come to that room and just summarize what they did. But this time around, like you can see there's a dashboard showing different KPIs, and they were able to look at the data properly beyond people just coming from the local government to say this is what we achieved, these were the issues, and all of that. So that was what happened there. And so they're able to look at their team's performance daily, track key performance indicator on the dashboard. There was also anomaly detections as well, proactive error identification. There are cases like in the first day, as part of the flow of the app is that you administer consent to the household. And so some CDD do not really understand that flow. And so we had a lot of refusals. So if you are not able to administer the consent properly, it means you cannot proceed. And so there will be a lot of refusals. So we noticed as a lot of refusal in the first day. And so we had to look at what was the cause, and we identified that they were not administering the consent question properly. That's why that happened. And so proactive error identification, efficient resolution, and we're able to get people to resolve that on time. And the outcome was basically improved response to field issues and enhanced data accuracy. Usually, if we do not have this, we will wait till the end of the campaign probably to be able to make these changes. But this allows us to improve the response time and oversight regarding the data that comes from the field level. We also had insight and strategic change using the geospatial map as well. So highlighting areas of low and high coverage by location. Right, because as I mentioned earlier, most of these things are usually verbalized. Oh, this is what happened, and that is why we are not able to pinpoint where did it really happen. But there was improvement in being able to track issues down to the location where it happened. And just to state another instance that beyond the high level of refusal, seeing that, okay, this particular LGA had high level of refusal, or there was a clustered administration, we were able to, using the map, drill down to the actual location and the CDD that was responsible for that particular location, and were able to address that efficiently. So identified location with high refusal, we were able to identify out down to the location level, and that was resolved, and the CDD responsible for that. What I mean by CDD is community drug distributors, were able to resolve that as well. Also, another improvement we noticed was on the real-time commodity management. And as you can see, there help for easy commodity data accountability. This was from the community drug distributor, from the qualitative feedback. So we're able to real-time tracking of data on the dashboard across all the different KPI for commodity management, the quantity supplied, quantity issued, quantity used, and all of that were able to be tracked. And also this allowed the logistician, usually, they are not able to know how to manage the stock out of commodity and all of that. All of this way really labor intensive, but now you are able to clearly visualize where are the shortfalls, where are commodities stock out, or who is not doing the right thing. And also for the drug distributors, you cannot just distribute drugs when you don't have commodities. Part of the validation that is in the app, you can't proceed to administer drug when you don't have commodity, and you can't begin your work in a day when you don't have commodity. So all of these checks allowed us to have end-to-end visibility and accountability in the commodity management. So we're able to, and even in the reverse logistics, we were able to not spend so much time. Reverse logistics is one aspect we spend so much time to be able to reconcile what was supplied, what was returned, what was used. But with this, we had a real-time visibility via the dashboard, which enhanced early detection of stock issues, ensuring consistent stock availability and improved support supply chain efficiency. So I've talked about so many things, talked about the supervision, the geospatial maps, the feasibility it allowed us across all the supply chain. But these are just a few challenges I want to mention regarding data completeness. So many CDD distributors were reluctant to synchronize their data, because when we talk about data use, you're talking about availability of data, right? And even if you are using technology, if that data doesn't get to where it's supposed to get to, you can't make any decision. So one key thing we noticed is that CDD were reluctant to synchronize their data. Of course, they are working offline, but they will require to go online to synchronize their data as much as possible so that we have almost near real-time data. But one challenge we noticed that they didn't do that quite a lot, so we had to intensify effort to make sure that the data is coming in, because there are going to be reviews at different level up to the state level, and also reporting timeliness. Because we're working at the community level, there's issues with internet. A greater percent of the local government struggle with internet issues, so that also impacted the timeliness of reporting as well. So while we introduce technology, there can also be those other technicalities that can hamper effective data use as well. And also there was also some underutilization of the dashboard, because each level are supposed to be using this dashboard, but majorly where we noticed that this dashboard was used was at the LGA level and at the state level. And so, but what we want to continue to advocate for is that the CDD supervisor, the first level supervisor of the CDDs, or those working at the community, are able to use this dashboard, and we're working around making that available on their phones so that they don't need to carry it on their laptop. So these are also key lessons that we have learned, that while technology is also good, especially because this is community intervention, you need to do a network assessment, right, to be able to assess where you are deploying your CDDs to ensure that there's a good distribution of these CDDs based on the type of network that they use or the availability of network. Also enhance training to ensure all campaigns implementers are trained in effective use of dashboard. While we know that data use, especially daily review meeting, happens majorly at the LGA and also happen at the state level, but because there also need to be supervision at the lowest level, so everyone involved there also need to be trained. Enhanced feedback mechanism is also one thing we learned, establishing a more structured way, because a lot of people can be giving information in the campaign chain, making it difficult to have a streamlined way of communicating to those that are actually working, and continuous enhancement of the Digit SCM capabilities. I think for this part, it's already been done. So what we want is that if you want to extend the KPIs on the dashboard, you should be able to do that seamlessly beyond what is default set for the states. This is part of what we want to do, so that the government and the campaign implementers are able to add more KPIs on the dashboard based on what it is that they want to track. And these are key recommendations for us. Strong leadership and government engagement is paramount, and promote data ownership and effective data use. Like I said, for the situation room you saw there, those are all state people, the malaria program people, and all stakeholders involved in the campaign process. They are the ones that look at the data, so they need to own the process. So even though we lead the process, we should ensure that they own the process. And also effective partnership in the states on whatever it is we're implementing. This will ensure effective collaboration will enhance effective data use. So when we're introducing technology, we must make sure that we do a proper stakeholder mapping and ensure that each stakeholders in the state or wherever we're implementing this are well involved. Inclusive training, I've talked about this. Structured data review meeting. Yeah, so I mentioned that because they were using paper tool all along, these are their first time, so adjusting to a structured way of reviewing data was a bit of struggle in the first day. So usually they would just come and be talking, so you have to continuously emphasize that they should speak based on data, what is available on the dashboard, and not just what they thought. So establishing a structured way of those data review at different levels is very essential. And most importantly, beyond just using technology for technology's sake, we need to ensure that the data that we collect is continuously being reused across all levels, right? Like now for KB State, we have done SMC, we'll be doing another campaign, azithromycin and all of that. So all these data are being collected, so we need to find a way to see that if there's a way other campaigns or other implementers can use that data as well, it will reduce data redundancy or having to be collecting the same data over and over again that we are not sharing. Thank you.
Thank you very much for that wonderful presentation. I think she made very, very good points in terms of the data reuse. Very key point that also referred to the earlier presentation that Sid made on designing principles and so many other things. The next presentation would be from UNDP team who are based in Chad on UNDP work on data health, but also share their experience on data use, in particular Chad digitalization. If Angela is online, can we have to present Angela?
Thanks a lot, Robert, and everyone. Thanks a lot to you. Thanks a lot to Mercy for giving us the opportunity as UNDP to present. We would like to take a moment to remember Dr. Inyas, who has been leading on this campaign and the experience that we will be sharing. He has been a malaria champion. He has been an AMP, attending all the AMP meetings, and for this campaign, UNDP Chad and the National Malaria Program received an award. And I think it's important that today, as a community, as a malaria community, we also take a moment to remember him. Thank you. And then we can hand over to the different colleagues that will be presenting this presentation. Robert, we have multiple people online. But thanks a lot, and thanks a lot for giving us this opportunity.
Thank you. Should I start, Angela?
Please, Manish.
Okay, thank you. Good morning, everyone. My name is Manish Pant. I lead the work on digital health at UNDP, and very happy to be here. I'll give a quick overview of our work on digital health, and before handing back to Angela for the work, the great work that was done in Chad. So, UNDP's digital health work is guided by its health strategy and two other main key strategies: our digital strategy overall for the organization and the UNDP strategic plan. And broadly, our work globally across all the countries where UNDP works. Our work on digital health focuses on three main areas: one around reducing inequalities and exclusion that affect health, promoting inclusive governance in health, and building resilient and sustainable health systems. So everything we do in digital health is basically around that element. Next slide, please. To that end, we have set up a digital health for development hub that supports our countries globally. We have four main areas that we work on. We provide technical advisory services to our country offices. We have over 140 country offices worldwide where we support them on digital. We support capacity building initiatives of the governments for improving health service delivery, support research, knowledge management, generating best practices to share amongst countries, to learn from one another. And given our presence around the world, we leverage partnerships with UN and non-UN partners and promote South-South collaboration and peer learning, all towards strengthening health systems. Next slide, please. So this is a snapshot of our digital health interventions. Broadly, we have big or small size digital health interventions in 90 countries, focusing across 25 health areas, which includes HIV, TB, malaria, supply chains, etc. Next slide, please. And this is broadly the digital health offer. So our work in digital health supports digital health transformation in a country. So it's not just about apps for different programs. It's about supporting our digital as part of countries' digital transformation through strengthened governance, capacity building, interoperable digital health solutions for all the use cases that we design. And we also promote innovation with AI and digital wallets, virtual care. All of these are coming in various forms and with various use cases in health sector, and we are looking to promote these technologies in the relevant areas. One of the key areas where the entire UN system led by WHO is working is digital foundations in health. So all our digital solutions that we design, whether in-house in UNDP or the ones that we work with partners, are solutions that are offered as digital public goods, open source solutions, aligned with WHO standards, and promoting the digital public infrastructure, which is the key foundational element in the country. And these are essential to build any digital solutions in any health programs. And most, for me, one of the most important aspects is digital should also have inclusivity and protect human rights. So we look to work with technologies around the world, wherever we have done work, to support technologies that protect human rights and address the challenges of privacy and discrimination, gender and equity. Next slide. And this is just to highlight the last point, the previous point I made. Our guiding principles around digital are based around keeping people at the center. I think people-centric digital systems are the key. They should leave no one behind. Digitalization in a system can exclude people, particularly the vulnerable, marginalized, or those on the other side of the digital divide. So we have to ensure that is not the case. Contribute to global frameworks. I think this is where the digital development principles are important. That work we do as a digital public good can be built upon and expanded globally through promoting open standards, open data, open source, and then strengthening local digital ecosystems. We aim to always work with local developers because they have the best idea of the technology required at the local level, and building strategic partnerships with partners, developers, academia, so that the digital work in a country is effective and inclusive. And this is the last slide from my side before I hand back to Angela. This is essentially our overview snapshot of how we approach digital health transformation to building resilient health systems. There are three layers that I like to call them. At the foundational level, we work on policies and programs through our country offices and the government relevant ministries. Specifically is focusing on digital public infrastructure, interoperable e-health architecture, governance mechanisms, which are very critical and have been highlighted in the previous presentations and the opening discussion that started today's presentations. Then enablers and governance layers are essential components for our implementation. So when we're looking at an implementation model, we are looking at capacity building, knowledge management, sharing best practices, South-South cooperation, bringing our global organizational knowledge across countries. For example, the work done in India and Indonesia at scale has been replicated in many ways in Malawi, on digital. And so there are the various examples that we push across our system. We are now looking to expand our innovations in more open source digital public goods, AI becoming more relevant, and then promoting learning. It is always important to share learnings, and we have a website that you can also access, digital UNDP digital health website, where we have put all these learning materials, best practices that you can access. And finally, on top of these foundations are digital solutions. I've highlighted 4 that we have worked on a lot: medical logistics, digitizing supply chains at scale. These are all at scale: medical waste management, beneficiary services, including telemedicine and campaigns and routine programs. smart health systems that rely on big data, sensor technologies, solar technologies for clean energy in the health system. So this is the broader framework, and within this, the work of CHAD highlights how we supported a mass campaign for malaria. And I'll hand back to Angela to take us to the rest of the presentation.
Thanks a lot, Manish. And if we can move to the next slide, Robert, please. We will be walking you through to the experience of the digitalization of the mass campaign in Chad. And I know Dr. Diar, Dr. Clément Eolé from National Malaria Program and UNDP Chad are also in the room. My name is Angela De Tomasi, and I'm Program Advisor within the UNDP Global Fund Partnership Health System team, sitting in Copenhagen and providing support to country offices implementing Global Fund grant. The idea of the planning of for digitalizing the mass campaign was to respond to some of the challenges that both the National Malaria Program and UNDP had faced in implementation of previous mass campaign, and those are related. The challenges are related to the disease burden, to the logistical issues in the country, but also, as Dr. Dorcas mentioned, some of the limitation of paper-based material, which can be lost, can be damaged, and led to a number of issues on data quality, inability to review, and also inability to have access to complete data information. And most importantly, because of the collection element related to paper-based material, of course, the lack of real data availability, so which will delay the decision making. So in addressing those challenges, next slide, please. The process that led to digitizing the mass campaign, similar to what Sid said, it's a full systemic and integrating process, learning from the chemioprophylaxis campaign and integrating the lesson learned of a pilot in the chemioprophylaxis campaign into the mass campaign of the L Alliance. A first and important element in this process had been the selection of a tool that would be a tool user-friendly, with the possibility of using it in remote areas where with no internet connectivity, and that could be used for the different step of the mass campaign. In the context of Chad, the tool that was used was Kobo Toolbox, which was the tool used for the mass campaign. But we will see that it was not the only tool. So the first part of the process was making sure that all the tools, but also the processes, the procedure, the SOP were made digital, to make sure that there was a correspondence between the paper and what was a computerized system. Cascade training, and we will see that one of the lessons learned from this campaign, it's cascade training at all levels, but not only formal trainings, but also on job supervision and continuous accompagnement of the different health workers and actors involved in the campaign, to ensure that whatever issues, mistakes could be addressed. And the third step, as I said, the Kobo tool was one tool, but it was not sufficient to make sure that data could be accessible, visualized, and ensure that data could allow for real-time decision making. So it was an important process, was the integration of the tool with the DHIS2 and the Power BI, which has then allowed also for reporting. I think Dr. Dorcas also mentioned the importance of piloting to test the tool, to understand the issues, to identify the challenges and be able to address. So there was a pilot in one of the districts with 2,600 households that were allowed to evaluate the full process. And then the intervention when scaled up. Next slide. So yeah, as I said, all the different steps of the campaign were digitized. So the enumeration, the distribution, the integration of the stock management, ensuring that also data related to the availability of the nets at the different distribution point were also available. The 5% re-enumeration. So this was done also with the support of the Against Malaria Foundation that supported and contributed also to this campaign. And we will see in one of the slides after how the visualization through Power BI and the granularity of the information, to have information by household, by team, helped addressing the challenges when the target that each team had to meet per day, per week, and per month were not addressed, to allow the National Malaria Program to take decision and adjust, but also to be able to replenish whenever there was potential stock out. Next slide. What were the main implementation challenges? I mean, very similar to Dr. Dorcas, what Dr. Dorcas mentioned. One was the limited internet connectivity. So in some of the remote areas that had poor internet connection, this wasn't possible for the health workers to upload the information, so which led to delays. The mitigation measure for this was to use offline data collection, but to identify setup synchronization point where, with better connectivity, where this information could be then synchronized and then being available at Power BI, DHIS2, so that the data were shared on real time. End user skill gaps, I think this is an important element also to the point that Manish was making as a cross-cutting element of the capacity development, making sure that health workers were trained, and that it was found out that it was not only sufficient to train. So the team, the National Malaria Program and UNDP identified as a mitigation measure the use of district technician to accompany at the district level the distribution. So to be able to also troubleshoot as issues were arising. And then data quality program. I think even moving from paper-based into a digitized tools with the multiple forms, so this could create some confusion and in terms of also the update. So for the mitigation measure, for data quality issues, they set up, the National Malaria Program set up some central checking system that allowed to also address some of the challenges that were identified on the data quality. Next slide. So the achievements are, very great achievement. And as I said, the National Malaria Program and UNDP received the AMP awards for this 2023 campaign. 17 provinces were supported with the distribution. 3.9 million households were counted. 9.4 million bed nets were distributed, but also 150,000 bed nets were also provided to the refugees from Sudan. These are the numbers, but there were cross-cutting elements that are related to the supply chain management, so the availability of data stock at all levels allowed to anticipate any potential stock out, and so be able to replenish and to respond quickly, so that there was no interruption in implementation of the campaign. Having access to the real-time dashboard, so this allowed the program, as I said, to monitor, to understand what was going on in certain provinces within teams. So to be able to, whether through training, whether because of lack of nets or whatever issues, to be able to respond it. And then effective supervision. So this was at all levels, from National Malaria Program, from the district, ensuring that there was really supervision for the different steps of the mass campaign. Next slide. And yeah, yes, they are. You have some of the data visuals of the data that could be accessible during the mass campaign, and you can see the granularity of the information by team in district, in certain, so that the information could be any challenges could be addressed, but also to allow for the monitoring of the campaign. The next slide. It's another data visualization from the DHIS2, because as we said, the tool that was selected was interoperable with the Power BI and with the DHIS2. Next slide. So here are the key learnings from our experience. As we said, workflows, availability of workflows and SOP essential to ensure that those are available, are clear, are user-friendly through job aid, so that all the actors can understand and use. Leverage existing digital solution for last mile. So as we said, deploy offline solution and cloud-based for real-time monitoring. Local support, so on top of the availability of the National Malaria Program on UNDP, but the involvement of district technician to supervise, but also to support. Multiple support methods work better than one, so being able to adapt the technology so that it's the training, the supervision, and the involvement of the district technician, and importantly, the ownership of the process by the stakeholder at all levels, whether at decision-making within the Ministry of Health, but also at the lower level. So this was an important element of the success of the mass campaign. Over to Angela. Thank you very much.
Thank you so much, Angela, and greetings to everyone sitting there and also online. My name is Angela Marques, Program Specialist in the Global Fund Partnership and Health Systems team, and as part of Angela's team, also based Copenhagen. So to close, we would like to share with you that some of the key learnings that we have been hearing today and in the past days have been an inspiration for us to innovate on solutions towards this digital future and to contribute to the transformation curve. To accelerate the Agenda 2030, partnership for the goals we know there are a must. So rethinking to build these future smart partnerships, the UNDP HIV and Health Group, through its Digital Health for Development Hub, and also the Global Fund Partnership and Health Systems team. Together, we established in last year, October, this global partnership agreement with e-Governments Foundation. This is a pro bono global agreement ready to use, but all the details, more information on this partnership, you can find it in this presentation links, including the focal points that you can reach out for further engagement. So today, and with our little time, we would like to highlight to you some key messages, and namely highlight the example of Burundi, who anchored on this partnership, is already thinking ahead and implementing its mass campaign on this risk-based, with this risk-based tool, let us say like that. So, and as Burundi, Burundi is already inspiring, namely Guinea-Bissau, to also be engaged on this digital journey. So both countries are already exchanging to be learning as we go and being more prepared. So this is just also to share with you that these key lessons that we are learning from current implementation will be a key pillar to inform the decision-making for future mass campaigns. So as we aim to promote better preparation for future donor programming, especially in the context that we are living today. we also would like to share with you that this is just the first of the next generation's partnerships that we are planning, foreseeing country enablement and flagship initiatives. Country enabling by strengthening our corporate offer to support countries in being future ready, aligned with the next UNDP strategy that we all know and hopefully all are contributing to, and to build opportunities with optimized resources, reskilling, developing a sustainable data infrastructure that can increase transparency, traceability, and accountability, and prepare us better also for the exercises that we have, and namely audits and others. For this, we will keep investing in initiatives like these global agreements that are immediately available to be used without further procurement processes, ready for adaptation to be tailored to the new context, and that enables this readiness, this donor readiness that we frequently and more in crises are we asking for, and we need to be ready for that moment. And also this type of initiative that will enable us to identify these mechanisms that can be more flexible to also engage our partners at the local level. And like this, promoting this healthy flow, this cascade implementation that my colleagues were also detailing before. So this is just some key message we would also like to share with you today, and in all the links you will have more details as needed. Thank you.
Thank you very much, Angela. Thanks, Manish. And thanks a lot, colleagues, and we are available.
Thank you to the two presenters. I think we are a little behind time. So we open up for questions. I think we had two wonderful presentations. Dorcas talked a lot about some of the key things. Timely and available data allowed them to report in terms of also the true picture of what they were reporting, which was an interesting one, because she said in the past they were always achieving 110%, but when they digitalized, it was around 92%, so that gave them a true picture of what they had. Improve the response time, use of the maps or the coordinates to be able to trace specifically where they had made. So these are very, very useful points. We also heard from UNDP some of the reasons why they had to digitalize, limitations of the paper-based, lack of real-time data to make informed decisions, and they looked at some of the challenges as well, including data quality problems among others. So we have a few questions online. I will start with that, and then we can take questions before we go for a coffee break. So for our first question online, considering that data collectors used their own devices, did the program provide data for the data collectors? I believe this is for Dorcas. On data security, was data retained on the user devices? Are there mechanisms to revisit data captured and make corrections? So I think this will be for Dorcas. Any other questions before we start responding? Yes, Zander? Okay, so let's start from the 1, 2. We take 3 before we respond.
Okay, thank you, Robert, and thank you, the presenters, for the very great presentations. My question goes to Dorcas. It's something related to where they come from. I don't know if they have time to do this analysis related to the envelope before the implementation of the SMC and the size of the envelope, of course, in terms of operational costs, not considering the investment cost. So have you managed to do this analysis? If yes, would you mind sharing with us just to compare the envelope before and after?
There's one in the middle. Yes, sir.
Ok, merci beaucoup. Ma question rejoint un peu la question qui a été posée en ligne concernant l'utilisation des appareils, oui, justement. Aujourd'hui, nous savons qu'une des difficultés de la digitalisation, en tout cas, c'est la pérennisation, surtout en ce qui concerne les coûts des infrastructures. Ma question, c'est de savoir, est-ce qu'il y a eu une analyse avec l'utilisation de ces appareils-là au niveau comment j'appelle ça? Voilà.
Can you repeat the question? I think she couldn't hear or understand the question. Yep.
Il faut qu'il éteigne pour lui. Il éteint pour lui. Oui, en fait, je disais que un des soucis majeurs de la digitalisation aujourd'hui, c'est sa pérennisation, surtout en termes d'infrastructure. Quand on regarde les coûts d'investissement de ces appareils, ça coûte extrêmement cher. Maintenant, étant donné qu'ils ont utilisé la stratégie, l'utilisation des smartphones des enquêteurs, je voudrais savoir si ils ont pu faire une analyse de l'utilisation de ces appareils-là. Quelle est la leçon qui a été tirée par rapport à ça? Merci.
Good. I think I'll take another one from here. Stephanus.
Thank you very much. So my first question is for Dorcas. I really liked the way that you thought out and rolled out this, not only that you developed it, but also you have been evaluating it, so that's really great. So in terms of acceptability, when you did the evaluation, the acceptability was very high among the healthcare workers, but it seems to be a little lower for the community healthcare workers. So now, would you probably comment on that, what the key issues were with them in terms of really appreciating and utilizing this platform? The other one is, I think, the synchronization with data, particularly was, I think you mentioned, might have been associated with the, their hope to save data. So in terms of really the data use optimization and compensation, was there anything in place in terms of really compensate for data utilization? And how did it work, their devices, in terms of really entering this information? Is there a provision in this tool for them to be able to enter the data offline and then upload it whenever there is an opportunity to connect, or is this something a bit challenging at the moment? And my last question probably is related to the costs of setting up and running this system. Now, what could be the possible cost drivers in the past in terms of really maintaining this system using your own devices, especially when there might be occasions whereby those devices could be lost, could be replaced, and all those things. And what are some of the considerations around that? Thank you very much.
One last question before we begin. Okay.
Yeah, we appreciate the presentation from Dorcas. That's why you are really getting good comments. I also have similar questions, though somehow different in terms of data utilization for campaigns. Number one, did you have the inbuilt systems to look at your data accuracy, completeness, and validity? Because it is very important to make sure that your data is reliable for analysis. Then number two, the synchronization, I think it is beyond the relaxation of the community distributors. You need to look at it because you highlighted it clearly that synchronization was majorly due to the relaxation of the community distributors to save money on the data. You need to, it is beyond the community distributors. Then we have also documented there are some applications, especially the IT phones, where they user-friendly, especially with the communities, to make sure that your utilization can give you the reliable data. Then lastly, we have heard about real data submission, real data. We need to be defining some of these indicators. So what do you mean by real data availability? Thank you.
I think I'll allow Dorcas to answer first and maybe take two more before we go for the coffee break.
Hi, okay. Thank you. So there's quite a lot of questions, and I hope I was able to get all of them. But I think Robert can help if I missed out in any. So I will start with the first question that talked about the security of the data on the devices. So very important. We already know that the device belongs to the users, but of course, the system is also a role-based system whereby users will have to log in based on their designated credentials to be able to access whatever is on the phone. And so during the period of the campaign, yes, they have access to the data. And when we are done with the campaign, they no longer have access to that data. So like I said, that's one way that we ensure the security of that data. Well, the data is on their phone and there is nothing we can do about it. But most importantly is we're using a role-based system. So they will have to log in to access that data. And when we are done over the period of campaign, they no longer have access to that information again. Their accounts will no longer be active. So they're only able to access that data because we can't say when once you sync, it's part of the consideration we are thinking about with regards to the security of data. When you sync, we wipe off the data from your phone. That's tricky, right? So what we do is that you have access to the data, but of course after the campaign, you no longer have access to the data except your account is reactivated as well. So that's one way. Another thing that was talked about is issue of the relaxation of the CDDs to sync their data. Yes, it's part of the enumeration that we pay them for data, but we don't pay them before the beginning of the campaign. So, but they know that they will be paid for data that they use. So there is a specific amount that they are paid for data. Yeah, so they are supposed to recharge their phone and sync their data because they would be paid for. So at the end of the campaign, the same way we pay you for a service, data payment is also part of that. So also, yes, we cater for the data that they use, but those are still things you cannot control, right? So that's part of why supervision, number of people that synced their data is part of what we track on the dashboard to if you all the active users and if they synced or not. It's part of what we track, right? So if you are in the campaign and you are supposed to do your work, you're supposed to sync your data because we would pay you for that. The only difference is that we don't pay you when we start the campaign. We pay you after you are done with the work. So you are supposed to pay. That's why we enforce supervision through monitoring those that sync and those that that have not synced their data. So someone asked about the evaluation. We had high rate of the ease of use among the health workers. I think it was 100%, but the CDDs was roughly about is it 67%? So why that happened is still around the issues with syncing, because when we get down into the qualitative, when you said, okay, did you struggle with what area did you struggle with in terms of the use of the app? They said we really struggled and all of that, but when you get into their qualitative responses, it was more about their struggle with synchronization. So for them, that was quite frustrating because it's tied to their payment. So we have to see that you submitted your data daily on the dashboard. So for them, they just have to submit it. So when they when they're struggling with those internet, and by the time for review meeting, we are not able to see your data on the dashboard, it's a problem for them. So that struggle, in terms of, we struggled a lot with syncing our data. We keep syncing multiple times before it goes. It was one key area we noticed was why they said they struggle with the use of the app, not necessarily the flow of the app. So it was more about the struggle they had in terms of the synchronization of their data. And also just to mention as well, is that the app works offline. You only need data to sync your data. And so you are able to sync your data. We also had people that provided first level support. So if you're working in a community that's struggling with internet, they will help you take your phone to somewhere, maybe the health facility where there's internet, and help you to sync with that. So just to respond to that, that was what we discovered from the qualitative response in terms of how that low response for them. So costs in terms of using the cost drivers for using BOI, bring your own device. For us, for KB, and we had quite a lot of people coming to support us as well. For KB, one key thing stood out. We don't just begin to talk about bring your own device in the middle of the campaign. It's part of the selection criteria, right? So we introduce it from when you are selecting. It is the state people that do the selection at the health facility level, but we provide them with the selection criteria. So device ownership is part of it, and the specification for the device is part of what you'll be selected as well. But it can also be tricky because these are people that work at the community knows them, so you shouldn't disqualify them from doing their job just because you want to introduce technology, right? But we ensure that that is part of the selection criteria. For somehow, they try to meet that criteria, and for KB State that we implemented this, quite surprising, they all have very good phones. And in terms of the security of their phones, I think that they took more, they paid attention more to because it's their phones, right? So there was no case of loss of phones, there was no case of the battery going down. So I feel like it's something that was personal to them, so they took care of them. So we didn't have any issue in terms of they bring your own device. But what was important for us to note is that we didn't introduce it in the middle of the campaign. It's usually part of the selection criteria. And as we continue in the engagement, we keep emphasizing it across up to when we get to the introduction and the use of the app as well. Did you have? Okay, so in terms of someone asks about validation and completeness of the data, yes, all of the indicators and all of the KPIs on the dashboard, before we even get there, we have a data analytics plan. We have the M&E framework that defines the different indicators we will be tracking and how it is being measured. And so all of that that is what we use to set up the dashboard. And that is what ensures that whatever we are setting up aligns to each of the key evaluation metrics, key M&E framework and indicators that are measuring, and how it is being measured. We make sure that whatever is being coded or whatever is being programmed ensures to follow that analytics plans and the M&E framework. So we're not just looking at data. We're looking at data that came up from a standard analytics framework and an M&E plan. So yes, we have that to ensure that whatever we are measuring is complete and is well validated. Okay, what do we mean by real-time data? I think I kind of mentioned this as well, that it's real time because part of what we encourage is that while you're in the field, you're supposed to be syncing your data as much as possible. So don't wait, because we need to see where the issues are. So that's part of what I was talking about in terms of supervision and addressing issues on time, because these data are being reviewed at different levels. So the one for the state review meeting happens at the end of the day. So there are continuous reviews depending on who have access to the dashboard. So if you have worked and you are around where there's internet, you should sync your data. So we have that as well, real time. People are working and they are syncing, especially those working on the urban. But of course, those working at where there is no internet will have to wait till when they're able to get to internet and are able to sync. So we have real time and also near real time. So near real time is that it's not coming in as you are working on it, but then again, we probably can say near real time. I think that can be more correct. I don't know if I missed any question from what I was able to take. Someone asked a question there. I don't know if I missed that question. Okay.
Thank you very much for those great responses to the questions. I think our coffee break time is up according to our calendar or our agenda. So what we will do is that you can always interact with her, with Dorcas, once we are having coffee, to ask questions. I realized there are a lot of questions on the use of BYOD. On Friday, there's a workshop session particularly focused on this, where we will discuss the details of some of these things, how to go about it, how to do the selection of all that. So If you are interested, you can join that session to learn more about it. So once again, thank you, Dorcas, and thanks to the UNDP team for this great presentation. We will come back at 11:15. We are over time, so we want to come back at 11:15. So maybe you grab your coffee and tea and anything and just come back so that we can continue. Thank you.
Thank you.
I think we will start with our next sessions. We are behind time, so while others are coming in, we can start. So for our next set of presentations, unfortunately the team could not come in person, so we have two presentations that will be virtual. One from James Kiari from Kenya, who will look at how real-time insights improve health campaigns, looking at their experience with the use of data. And then we have another presentation from Tarina Arnold, who look at real-time data validation and analysis in Uganda's decentralized malaria IRS campaigns. So is James online? James, are you online? Yes. Can we unmute James for him to start with his presentation? James, if you're online, can you speak so we can hear you? Hello, James. IT, can you look at James? I think he's speaking, but we can't hear him. Okay. If James is not able to present, maybe we move to Arnold. Arnold, are you online?
Yes, I am.
Yes. So maybe can you move to the Uganda presentation? Are you ready for Arnold?
Yes.
Okay.
Good morning, everyone. Thank you, Robert. I hope everyone can hear me. Hello.
Yes, we can hear you. Please go ahead.
All right. So I'm presenting real-time data validation and analysis in Uganda's decentralized malaria indoor residual spraying campaign and leveraging the open data kit and the DHIS2 for improved decision making. My name is Simon Arnold and I'm from Ministry of Health, Uganda. Next slide. So as the world background, Uganda contributes the third highest global burden of malaria at 44.8%, and is the 10th leading contributor to the global malaria death at 2.7%. As a result, government of Uganda, together with implementing partners, is implementing the indoor residue spraying campaigns across the country. Next slide. For this specific presentation, I will focus on the regions of West Nile and mid-north of Uganda. In West Nile, we have 9 districts that IRS is being conducted in, while in mid-north, we have 4 districts. West Nile is the top left in green, while mid-north is the one in the center of the map in yellow. Next slide. Now, the main goal of IRS is to contribute to the reduction of morbidity and mortality due to malaria in Uganda. And the objective is to reduce untimely interrupt malaria transmission by reducing the vector survivorship density and human vector contact in a manner that is safe for human health and environment in targeted population. Next slide. We were using paper-based approach previously, but we had a lot of challenges. Delayed data transmission. Data collected on paper takes time to reach decision makers, delaying timely responses to any operational issues that could arise. We also had challenges of data entry errors. Manual transcription from paper to digital format increases the risk of errors and inconsistencies. There was a lot of cumbersome data management. Handling of thousands of papers daily is labor intensive, increases storage needs, and complicates retrieval for audits or analysis. We also had an issue with limited real-time oversight. Lack of immediate data visibility prevents rapid identification of low coverage areas or operational bottlenecks. We also had poor data quality assurance. We were having challenges with the quality assuring the data. It was difficult to validate data in real time, leading to gaps in accuracy, completeness, and consistency. We also had difficult to trace errors or omissions back to the specific teams or individuals due to lack of digital audit trails. Next slide, please. So what is the approach? For each house that is sprayed, data is collected and entered into the spray cards. And indicators such as structures sprayed, population protected, number of houses found are captured. This ensures comprehensive household level data is captured as a primary source for monitoring campaign reach and effectiveness. Next slide. So for every day, the supervisors at sub-county level aggregate what has been done in the different villages into an ODK system and send that data through short SMS. This of the campaign performance. It helps us quickly identify low-performing areas, immediate action and resource allocation, and then better local coordination among the spray teams. The image below is the pull-out of the IRS daily SMS dashboard. Next slide, please. So then what happens? For this SMS dashboard, we display graphs charts as you've seen, and this helps us to identify areas that are lagging behind for deployment of more resources or conducting targeted community sensitization. It also helps us identify systemic issues like low acceptance rates. We have issues where different communities are not necessarily accepting the campaign or the intervention. So with this kind of dashboard, we can know where we have low acceptance rates and low spray areas. Next slide. So at the district level, this is where the spray cards are entered into the system by data entry clerks. This validation of this entry is done by the district biostatisticians, and the data is accessible through the Open Data Kit platform, where any cleaning can be done by the biostat in reference to the cards available. And then we later synchronize this to the DHIS2 on a daily basis. ODK enables digital capture of this and including geospatial tags where available, creating digital replica of field operations. What you see below is a pullout of a summary from the system for what is the details that are entered through ODK at district level. Next slide. I had spoken to this slide. With this kind of relay of data, it helps us into making impactful decisions and real-time decisions. Feedback is instant. For example, if someone reports more structures sprayed than those found, the system will automatically flag this anomaly, prompting the teams on ground or the district teams to investigate on the same day. Next slide. So IRS data is digitalized nationally to DHIS2. This integration allows ownership through Ministry of Health, accessible for real-time dashboards, and is used alongside other interventions like IT and distribution. Next slide. Unlike the paper-based system, which caused a lot of delays, like identifying issues, digital tools that have been deployed for IRS allow real-time validation, visualization, enabling rapid evidence-based decision-making at sub-county, district, and national levels. We are using two platforms that I had mentioned earlier. Next slide. So before and after, while we're using paper-based, it would take about 7 to 10 days to transmit data, but it now takes between 24 and 48 hours for us to have this data, depending on the specific site and the internet connectivity issues. Error detection, we would only do this after the campaign, because then we have to go down on ground. The teams have to go down on ground and verify what has been entered into the paper. But now we do error detection in real time as the campaign is ongoing. We had previously with paper-based, we had delayed reporting, and delayed decision making. But now there's daily decision making and daily reports. Previously, we had manual summaries that we would have to look at, but now we have live dashboards as seen in the previous slides with charts and maps. Accountability was also an issue because insecticide and all other equipment that has been used for the campaign, but now we can trace it based on who sprayed where and what was sprayed. Next slide, please. So the key benefits of digital to national level, less than 24 hours, within 24 hours. Managers at different levels, both district, sub-county, and national level, acts immediately and correct campaign weaknesses if they arise. There is integration because now it is in DHIS2, a platform that has all other interventions and all other disease components. This is sustainable for Ministry of Health because there's ownership. There's dependency, it reduces dependency on any other parallel systems or donor-specific tools because the ODK is housed under the Ministry of Health as well as the DHIS2. Next slide, please. So in conclusion, the digitalization of IRS has helped us as a Ministry of Health in integration, in visualization, and transform decision-making. We have managed better spray operator performance, reallocated resources for the right use during the campaigns, post, pre, and after. Then these tools have also empowered managers to respond faster, smarter, and more effectively to fight malaria. Next slide. So in conclusion, We thank the Global Fund and the Ministry of Health for supporting this initiative, and I thank you all for listening.
Thank you, James. Arnold, sorry, for this presentation. I think our colleague James is having technical issues, dicta meeting, but we are having dictalization issues. So he's not able to speak. On that note, I think we can take some questions for Arnold before we go into the next set of presentations. He mentioned very, very good points, and I think one of the ones that I picked up was that previously it would take them about 7 to 10 days before they have the data. With digitalization, within 24 hours, all the data is there. So that ensures that they have real-time data to make any informed decisions. So I think these are some of the highlights or some of the benefits that he highlighted. So I'll open it up for questions in the room and any questions in the chat. Yes. One, Christian. Any other? Yes, number 2. So let's start with Christian.
Hello, thank you. Wonderful presentation. The first question is clear you use digitization for the sprayers, but do you also use it in other key activities of IRS like enumeration and supervision, and how has that also transformed your activity? And the lighter one on the picture, I saw a picture of IRS. I'm not too sure if it looked like an aerosol being sprayed, and if that's how you do your IRS, just curious, and not with the one we know. Over.
Yes, go ahead.
Yeah, thank you for the presenter. So I have 2 to 3 questions. So first is related to data entry challenges. So the process of taking spray card to the district for data entry and validation seems efficient. But have you encountered any challenges such as delays in data submissions or errors during entry? And how are these being addressed? Second is related to, cost implications. What has been the financial impact of adopting digital tools like ODK and DHIS2? And have the cost of implementation been offset by the benefits in terms of efficiency and effectiveness? And last question is related to future plans. So what are the next steps for the IRS program in Uganda? And are there any plans to, expand the use of digital tools to other aspects of malaria control, such as bednet distribution and case management? Thanks.
Any other question? Yes. Medad.
I come from Uganda, so I'm not making questions, but I'm making more information and character. Number 1 is that we give acknowledgement to PMIUSAID for giving Uganda the benchmark to Global Fund to implement IRS using the government structures. We had huge experience as part of the transition from the project mode to the government implementing structures under Global Fund. Global Fund supports Uganda to do IRS through the government structure. So it is possible and sustainable moving forward. Then number 2, we also need to appreciate that our IRS indicators are digitally tracked by looking at the progress, daily progresses of individual manpower, household coverage, and also insecticide use rate. So we are in position to tell individual performance and also geographical performance of IRS. So we have had IRS implemented in a project mode for some good time, but I call to all the countries that it is possible to mainstream it to make sure it is efficient and cost effective for implementation. Because one of the recommendations with the current financial crisis is to scale down IRS and possibly scale up also some key interventions, but we can look into the cost drivers to make sure that we maintain IRS as one of the key tools for malaria vector control. Thank you very much.
Thank you for those additions and clarifications. And maybe one last question for me if you can also highlight how you ensure that the lower level have access to the dashboard and are using it to make decisions. Most often what we see is that this is only accessible at the national level. So can you share your experience on how you are ensuring that those at the lower level have access to this data to make all the decisions you spoke about? So Arnold, over to you to answer the questions.
Thank you so much. I was trying to note down. I hope I picked most of the questions. You'll help me, Robert, if I missed any. Christian, do we have digitalization in other interventions like supervision? We are trying to move supervision for IRS to ODK. We have a few reports that have run from the previous campaign. We have had good results because then we can track if someone is actually doing the supervision or not, if they are doing the right supervision or not, because of the reports they are bringing in. The kind of report supervision that is being done is specific. How many spray operators have you found on ground? How many houses have you verified in the system vis-a-vis on the card? So it helps us track. We are moving this, but not at the high level. Then the second question, I didn't get the name. Any data entry challenges in regards to the fact that there's daily data transmission? Yes, how do we avert this? We have daily meetings every day of the campaign. The campaign lasts between 21 to 30 days, give or take. So every day, at least a week before the actual spraying starts and 5 days after it stops, we have meetings every day. So for every data error, for every challenges in submission of data, maybe due to connectivity, poor terrain, we address the problem in the evening meetings. Our evening meetings happen every day at 8 p.m. I hope that answers the question. The second question from this second person who asked the question was, any financial implications? ODK is such that we share a link to the different data entry clerks and supervisors. So you log on onto your phone. You don't need any device. You just log onto your phone and submit. We have put it in such a way that we pre-enter the specific spray operator code, spray operator names, so that not anyone can enter data into the system. Any future plans for IRS? I think Medad has hinted bits and pieces of that. Then I also want to thank Medad for the supplement. I appreciate. Over to you, Robert. I don't know if I've forgotten any question. Oh, Robert, you had a question. How do we ensure that lower level people get access to these dashboards? ODK is, we have given rights to biostats, district biostatisticians that are cascading those dashboards to the lower levels, to the sub-counties. So they have access to the dashboard, they have access to the data online. So during their health meetings, during their daily meetings, they're presenting these and giving a snapshot or summaries to these specific sub-counties. Over to you, Robert. Thank you.
Thanks a lot for this wonderful presentation and also for the clarifications. I think we have James online, but before he starts, can I have Boubacar Sadiq from Mali here, and also Wani Kumba from Sierra Leone? Can you please join me here? I think we will do the 3 presentations together before we take questions. Good. James, are you ready?
Yes, I'm ready.
Can we move over to James' presentation?
I hope I'm now audible without an echo. Confirm, please.
James, we can hear you. Archie, can we move over to James' presentation? Yes, James, you have the floor.
Yes, thank you. My name is James Kerry. I work with the National Malaria Control Program Kenya, and I want to give a brief presentation on how health insights have helped improve health campaigns. Next slide, please. Yes, so based on the outline of the presentation, look at the previous implementation, just a few highlights on how this was done before the digitalization, and also the inefficiencies that we observed in the manual system. And then we look at the current digitized campaign and provide a few highlights of the benefits around the digitization. Next slide. The community, so the previous campaign involved the manual process of undertaking the full process of the MassNet, which begins from macro planning, then trainings on micro planning, and then subsequent to that is the household registration, which involved the community team, which incorporated the CHVs and village elders designated to the lowest level within the organization hierarchy of the country, that is the village level. And each of those teams will register, a pair of two will register households within their catchment population, that is the village, where they are designated to do. Then subsequent to that, this will be done through a paper-based register, and then they will work from house to house, and their data will be summarized once they're able to complete the registration. Then they will submit this to their supervisor at the sub-location level. And the supervisor, once the data has been verified, then the summaries, that is the summaries for each village, would form the sub-location summary, and then those will be in turn be summarized into the ward summary. Then at the ward level, the data will be uploaded into DHIS2, and that was the level at which at national level and also at sub-county level, we had visibility of through the DHIS2 platform. And this meant that whatever was happening below that was based on Excel and paper-based summaries. Next slide. So then the same case would happen during distribution, whereby distribution of it will happen through fixed distribution posts, and the household registers would be matched to form a post register. That's if post serving two villages, then they would literally be able to fix to those particular registers and attach them to become one particular register, or have both of them separate, so that as communities come and collect the nets, then they will come and issue the nets. So then there will be an SBC component for which they will be able to broadcast to the teams to come and collect the nets. Then upon the day, once the nets have been requisitioned from the central warehouse, they will be brought down to the drop-off stores and subsequently to the fixed distribution posts where the issuance of the nets would happen. And the householders will queue at each of those posts during the period of distribution, and they would physically sign against their name in the register, just confirming that they have picked, and they will use the ID to be able to verify the details, and then they will proceed to collect the nets and move away from the posts. Then post data will be aggregated, and daily post summary will be populated in a paper register, in a paper summary, and then that would be aggregated from each post at the ward level, and then now at the ward summaries would be uploaded into KHIS or the DHIS2. So the sub-county team were the ones who are responsible for uploading this data onto the DHIS2 platform. Next slide. So this is a sample of the register that was used before, and I will not labor much to it, just contains the details of the household, the ID, the phone number, the number of persons resident in that house. That is the first section during the registration. And then subsequently is the number of nets that have been allocated or assigned, depending on the number of people in the household, using the universal coverage 1 net for every 2 persons. And then the next column looks at vouchers, if vouchers were used to redeem the nets, then the number of nets issued, and subsequently the details of the household head, the ID number, and then that is the last section where they will sign off. Just move to the next slide, please. Yes, this is a sample of a snapshot of what it entails, the population. So you see the aggregation at the bottom is what will form the sub-location summary. Just next slide. Yes, and this is a sample of the summary, the word summary, just highlighting the words. And this is the information now that would be uploaded to DHIS in the next slide. Yes, so that was the DHIS2 platform that was used back then. And you see, during distribution, we could be able to indicate what the number of nets distributed in each post. And that is the only visibility we had as at clerk level. And then that would aggregate to the ward, sub-county, and then county and national. Next. So the inefficiencies, just too much paperwork and too many summaries, paper-based summaries done before uploading. You realize the hierarchies that we've talked about. And because of a lot of aggregation and some of these posts are quite vast and the different regions within the sub-county. And also the villages are quite vast. So getting this aggregation and getting the right aggregation to loading into DHIS first took a bit of time. There was also inaccuracies because of arithmetic errors of addition that may arise because of the manual process and considering using quite a number of villages. Then the lack of visibility of household registration data at lower levels was also a key challenge. And then time lag of up to even above a week, some instances even 2 weeks, from the completion of household data to the submission of this data and to have this data being uploaded into the DHIS2. So which means there's lack of visibility of what was happening, and that also led to the delay in implementing the campaign. Next slide. Yeah, then again, during distribution, difficulty to determine the actual ITN need for each distribution posts, resulting in interpost transfer of nets to serve the registered population. So this meant that there was a lot of inter-movement of nets across, and that again delayed the period when the distribution would start, and in some instances nets would be finished within a post in the first or second day, and they have to wait for a consignment to be brought in from another either another post or a drop-off points. And then too much paperwork again, I alluded to that. Then time lag between the completion of the registration to the tabulation of the summaries, that's the distribution summaries, and to uploading the data into DHIS2. Then logistical challenges of determining the quantity of nets to be allocated to each distribution post, especially if the actual quantity after registration differed significantly with the quantities determined based on the micro-planning estimates. And then as a result, again, we also observed inadequate nets leading to capping of nets, whereby if a household was designated based on registration to receive 5 nets, depending on their population, and the team managing the posts determined that nets will not be adequate, then they would be able to cap and may indicate that they're giving a maximum of 3 nets for each household, and that led to inefficiencies and in achieving the campaign objective of the universal coverage. Then, as a result of that capping, we also observed some nets, most of the nets actually remain after the period of distribution, because of either movement of nets across different posts and the idea of capping, which leads to us not achieving the target despite having nets remaining. Next slide. So I want now to focus on the current campaign and the digitization, the actual digital process. So it took around 1.5 years to actually have the editions, from the edition stage up to until when we actually managed to distribute the nets, and up to around 1 year for the process of developing this. That starts from the ideation stage all through to the having the SR system, software requirement system, the SRS in place, and then the design and development of the platform all through to up to until when we had the pilot in April of May, and then the various meetings to be able to ensure that the process went through around that. And then we had the launch of the campaign in November of 2023. And throughout from that process, it was a marathon up to until when we actually distributed the nets. And the projected date, completion date was scheduled to be June. But however, we had a few overlaps because of delay in some of the consignments of arrival of nets from outside the country. Next slide. So the key components of the campaign that were digitized, one is the master list management, which is purely a list of all participants involved in the campaign. Then all events related to the campaign are also fully digitized. That means all meetings, all trainings, those are the events, activities, supervision, and all the other key things, the management around either facilitation and also participation or signing into meetings. It was done through the platform, which was called Digimal. Then the household registration, post the trainings, the household registration was done through the Digimal platform as well as issuance of nets. In addition, we had the inventory management also done through the platform. And lastly, the payroll management. So it was purely, we didn't have any paperwork, right from implementation of the campaign all the way to remuneration. It was done through the platform, which the platform was integrated with the M-Pesa, which was used to make all payments for all participants involved in the campaign. The only things that weren't integrated within the campaign were fuel management as well as venues procurement. Next slide. So this is a snapshot of the key events. So for each meeting or each event that took place within the campaign had a unique event code. And if you are to drill down within the event code, you could view the participants and also the trainers, as well as the payroll status in terms of when the meeting took place. First would be if the meeting is still in session, and then if the payroll has been generated, I mean, if the event has completed, and then the last step would be to generate the event. The beauty of the platform was the event, or rather the facilitators had control or managing the event in terms of the participants of participating in either the meeting or the trainings or even the actual household registration. And then they will be able to indicate that the meeting has completed, and they will close the event. And subsequent to that, we'll be able to submit that to the accounts team to be able to again log in and be able to generate the payrolls for each of those events. And subsequently, once the payrolls were validated, then payment will be done, because the payment will be integrated with the payment platform. And once resources are available, then payment upon approval by senior authorities, then the monies will be dispatched to the relevant personnel. Next slide. Yes, so the master lists is the other key critical component that we observed in the campaign, which looked at ensuring that we had detailed names of all personnel involved in the campaign, and they will be stored somewhere. And then that will be loaded onto the Digimal, and then which included the personnel organization hierarchy, either from the national government administrative office or from the MOH or the county level, as well as partners in case they were involved in the campaign. Then the role for which one was delegated to be participating in. If you are a supervisor, that will be assigned for that particular task. If you are a facilitator, that will be picked as such. Then if you are a finance officer, that will be assigned the respective role. Then user level, because then we had users across different levels, those national, county, sub-county, etc. That would be the designated level of approach. So for community users, they would be mapped at the sub-county, but then their roles will be specific in terms of what each personnel was involved in doing. Then in addition, participants' validated job groups will be loaded so that for purposes of ensuring the payroll is payable based on the designated job groups. Next slide. So then the other key thing was the ability to incorporate new users during campaign implementation. Initially, we had stated that we would ride on having a master list approved and then implemented. Then later on, we realized that we had a significant proportion of users who want part of the master list and would be there was an embedded in section of incorporating new members. And then the win-win with the master list was mapping roles to specific campaign tasks for which one would be eligible to be able to undertake and be involved in without interfering with other tasks. Next slide. So this, I just want to give an indication of the process. There's a video. First, this process of how this was during distribution. So for registration, they would walk in to the households and would, using the USSD or the mobile app, will register households. And then post the process of households now is a distribution for which community members would queue to the posts for which they are eligible to come and collect. So part of integration, because as they did the household registration, they would use the phone numbers of the households, would have SMS broadcasted to households with specific dates set on which particular posts will be allocated to go and pick their nets. So despite us indicating that the distribution date is a particular date or a particular period, then messages would be sent to households, and then the households would trickle into the posts. And upon provision of the ID, they will be registered. So, I mean, they will be verified, and then the nets allocated to them based on the household register would be issued the nets. Next slide. I think it's a video. Yes, so I would request you play the video if you're able to. Okay, yeah. So what, maybe I can speak to what was in the videos, just the process whereby the household would present the ID and the CHP would easily be able to click on the input the ID number of the household head, and subsequently the system will indicate how many nets that particular household head has. I think it's showing on the tech support side. I don't know why it's not on the slide. And then once they indicate that, then the household head would proceed to the post, have the nets issued, and subsequently would just proceed home. If you see, look at the last section of that video, you see very smiley faces in terms of how easy it was to issue the nets. And as you've seen, within 6 seconds, if one was right fast enough, they could be able to issue through the system, and then maybe the other few seconds, maybe 1 minute, and so done. So the win-win situation for us was the turnaround time, around which when from when the household heads presented the post to when they received the nets was quite fast, and we didn't witness any long queues significantly, save for when maybe the team undertaking the distribution maybe had challenges in accessing the platform, but mostly it was relatively fast. I'll give a snapshot of a few data summaries around this particular process. Next slide. So you see, this is a registration from when we began. That was in November. That's December 2023, I think, which currently showing, up the way to the current period. And where you find that's a cumulative trend in terms of the national accumulation, up to until when you registered the 400,000 households that have all been registered. And where you find accumulation or some few peaks, those are around when we had multiple counties undertaking registration at the same time. Next slide. Then the picture of the county specific, you see, right from beginning, from the initial day all the way to the last day. So you, every time there's a registration, this data will trickle in and you're able to visualize, and we will be able to move in to check which are these areas or localities that have challenges or haven't started, and we'll be able to send teams to undertake the supervision exercise and also support to be able to ensure that we achieve the desired targets. Next slide. Then this is a snapshot of the achievements in terms of registration. For some counties, you see it's over 100%. This is purely because the targets were inaccurate in terms of the targets that the teams had. But relatively, we managed to register over 92% of the households, and through mop-up exercises and also timely ensuring that we try to reach as much as possible. Next slide. Then the distribution, you see we achieved over 94% of all the registered households, varied across different counties, and again, we are confident that because each of those registered households were their details were available and they could be called to come and collect, but that at the time or during the period of distribution, for one reason or another, they didn't manage to come and collect, for which most of these have since been mopped up, and the current picture would be different from what we are currently seeing here. Next slide. Yeah, so a few challenges and proposed solutions based on the implementation of what you observed. First, the master list generation and or rather creation was quite tedious to both the national team as well as the sub-national teams involved in mopping up this information. Then secondly, internet and mobile network disruptions. First, for mobile network, because of the USSD utilization, there are some regions with low network coverage, and that meant that we experienced challenges around that, up to and including the timeout. The platform will also have issues of timeout in the initial stages of the campaign. Then digital literacy gaps among the village elders and CHPs, introducing them to the digital platform meant that some of them would not be able to easily navigate through the platform. And then lastly, households without requisite registration documents. So what did we do around that? Then for, maybe next slide, for households without IDs, we allowed for merger of households validated. And also there was a section for which we were doing validation of households data through the platform, whereby the supervision team for the CHPs, that's the team who are doing the registration, would move in to check and identify numbers that were in the outlier section, and subsequently would be able to validate, and that data would be updated. And once the data is validated, which involved actual verification with teams at lower level, that's at the sub-location level, which means they're able to keenly monitor and track the registration data. The next slide. In terms of the digital literacy, rather the internet connectivity challenges, we deployed Android an Android app which had offline capability, and for some of those areas with low network coverage, the registration, the household registration will be done, and also the net insurance, and then later on the data will be synchronized and submitted to the cloud. Then for digital literacy, we developed easy to comprehend short videos for Digima tasks, up to and including virtual meetings that we had with the supervisors, just to be able to push them to guide on challenges that the CHPs were initially facing. And that was in the initial stages of the campaign. We observed some CHPs had challenges, but as we proceeded with the campaign, they were okay and did not have the major challenges that we had observed. Then in terms of the tedious tasks, I think this is something that we are proposing that needs to be picked up. It's not yet been resolved, but if any countries is picking up this process, there will be need to simplify the master list generation and the process of onboarding new users, so that it doesn't take a toll on the users of the platform. Thank you. I think I'm almost through. Then Digima will be accessed through multiple platforms, which was again useful for that. The web platform is for visualization. Mobile app was always useful in areas with low network coverage because of the offline capabilities, and then USSD, which meant that any basic phone that most users had would be used to undertake the key tasks, up to and including the user registration, which was a requisite after having the details in the master list, and house registration for from house, and then event registration and distribution. That's also available on those platforms. Slide. Next slide. Okay. I don't know if, yeah, last one. Real-time data to consumers. So that means users at various level. one registration of household data, we could be able to feedback the household beneficiaries in real time, even through SMS. Then order management of ITNs because of the integration. I don't know if I didn't mention that the NET's order management was integrated with the LMIS system, or the order management in terms of the Digimal and the KEMSA and MEDS LMIS platform, so that once registration was done and the data was validated in terms of getting rid of outliers, then that particular order would be pushed to KEMSA to be able to service the orders through the platform. And then the nets will be delivered and up to the distribution post, depending on the registration need. And then issuance of nets to household nets again was determined through that. Then we minimized the lag between the registration and distribution because it was nearly seamless and you could have the full view. Even when an error would occur, that would be easy to correct. Then another quick benefit was we eliminated capping of nets because allocation was based on registration need. I think that's Mark's end. Thank you. Next slide. Yeah, those are some of the key stakeholders involved in this. And thank you for the time.
That was a very, very comprehensive presentation on your process, and very useful and insightful innovations, payroll management. I think Kenya is doing well with the use of mobile money. You mentioned that while you are paying them through the system. SMS, which I would like to explore more in the questions, where you are sending SMS to households and the rest, the use of ID cards. I think these are very, very good innovations. Before we go into the Q&A, let's take the presentation from the two other presenters who are here because of time, and then we can go into the Q&A. So I'll start with presentation from Mali, Boubacar. So Boubacar will share with us on the role of digitalization in improving data quality for ITN distribution campaigns in Mali.
Ok, bonjour à tous. Donc, j'ai le plaisir de vous présenter la présentation du Mali sur le rôle de la digitalisation dans l'amélioration de la qualité des données pour la campagne de distribution des moustiquaires au Mali. Donc, il faut noter que la délégation du Mali est composée de moi-même. Je travaille pour CRS. Et du côté du programme, nous sommes accompagnés de la directrice du programme et du chef de division prévention, suivi et évaluation. Donc, depuis 2011 à 2020, le Mali a organisé des campagnes de distribution de masse imprégnées pour atteindre une couverture universelle. Donc, ces campagnes ont permis une distribution récurrente dans toutes les zones du pays avec un passage moyen de 3 ans. Donc, toutefois, l'utilisation des données de ces campagnes, notamment pour ce qui concerne le dénombrement, la distribution a été un défi parce que la collecte des données se faisait sur du support papier qui ne permettait pas, en tout cas, de faciliter les analyses à l'échelle du pays. Donc, avant la digitalisation, quelles étaient les difficultés auxquelles le pays faisait face? On avait un problème de qualité des données. Donc, étant donné que la collecte des données se faisait sur du support papier, donc cela entraînait des erreurs et aussi des incohérences dans les analyses de données. Donc, on avait aussi des défis dans la gestion du stock, notamment pour pouvoir suivre en tout cas les disponibilités des entrants à tous les niveaux de la pyramide sanitaire. Il y avait un autre défi qui était des défis de remontée des données. Donc, comme vous le savez, surtout dans les zones inaccessibles ou dans les zones où nous avons l'insécurité. Donc, après la campagne, on avait un problème de remontée des données au niveau national pour pouvoir consolider et faire ces analyses. Il y avait aussi des délais d'attente que le pays faisait face, parce que quand on faisait le dénombrement pour la distribution, les équipes recherchaient en tout cas les mélanges au niveau des coupons pour pouvoir faire la distribution. Donc il y avait aussi ces délais d'attente-là qui étaient trop longs avec la méthode classique. Donc c'est ce qui a amené le PNLP, avec la collaboration des CRS, à passer à la digitalisation des campagnes de distribution en 2023. Donc, avant cette campagne de distribution en 2023, quelle est l'expérience du Mali dans la digitalisation? Donc, il faudra noter que le Mali a commencé la digitalisation en 2022 avec une phase pilote de 10 districts avec la campagne CPS. Donc, c'est en 2022 que nous avons commencé la digitalisation et les premiers outils de la digitalisation ont été intégrés au Mali en 2022. Donc, en 2023, nous avons fait une extension de la CPS en passant de 10 districts à 16 districts. Et pour la campagne moustiquaire, nous sommes passés à 29 districts. Donc, initialement, c'était 46 districts qui étaient prévus pour la distribution. Mais compte tenu de la situation sécuritaire du pays, après une analyse minutieuse, donc 17 districts ont été exclus. Et nous n'avons maintenu que 29 districts pour faire la digitalisation de la campagne moustiquaire. Et après cette digitalisation, en 2024, nous avons intégré en tout cas d'autres outils à la digitalisation de ces campagnes de masse, notamment tout ce qui concerne la supervision, tout ce qui concerne les monitorages indépendants, tout ce qui concerne les enquêtes LQIS que le pays organise après la campagne. Et jusqu'à aujourd'hui, en tout cas, nous sommes en train d'avancer dans ce sens-là. Donc, ce qui est important à noter ici, c'est que depuis 2022-2024, compte tenu des contraintes des infrastructures nationales au niveau du pays, donc l'ensemble des données étaient hébergées sur les infrastructures de Blue Square qui étaient aussi notre assistance technique. Mais à la fin de 2024, le pays a pris les dispositions et nous avons pu transférer l'ensemble des métadonnées et des données de la plateforme de Blue Square vers l'infrastructure nationale, ce qui permet maintenant au pays de mieux gérer ou en tout cas de centraliser ces données de campagne pour une prise de décision. Maintenant, quand on parle de la digitalisation, certainement il y a des plateformes et des applications qui sont développées, qui sont utilisées au niveau du pays. Donc pour tout ce qui concerne l'enregistrement pour la campagne, nous avons développé des outils, par exemple le dénombrement qui nous permettait de suivre de façon individuelle ou de collecter les informations individuelles sur chaque ménage pour pouvoir suivre ça dans le temps. Nous avons aussi développé des outils pour la distribution, donc ce qui facilitait en tout cas la distribution des campagnes et la distribution des miltes aux ménages, parce qu'en scannant seulement le code QR, l'agent pouvait savoir quelle est la quantité de moustiquaires à distribuer aux ménages et la distribution se faisait sur cette base. Nous avons aussi développé des outils qui nous permettaient de pouvoir suivre la performance des équipes qui sont déployées sur le terrain, parce que chaque équipe avait des quotas à atteindre et le paiement se faisait en fonction de ces performances-là. Donc, ce qui nous a quand même permis de pouvoir atteindre les objectifs que le pays s'était fixés. Maintenant, d'autres outils ont été intégrés, notamment pour tout ce qui concerne la gestion du stock. Donc, le pays a bien voulu tester, en tout cas, la partie logistique aussi. Nous avons intégré par rapport à cela 3 outils. Donc, tout ce qui concerne la réception des moustiquaires. Et ça, c'était à tous les niveaux. Donc, au niveau national, quand les moustiquaires sont venus, donc l'outil réception était utilisé pour pouvoir faire la réception des moustiquaires. Et il y avait aussi un outil qui permettait de transférer aussi les moustiquaires d'un point A à un point B. Donc, avec ces 2 outils, ça nous a permis en tout cas de faire une comparaison entre la quantité de moustiquaires qui sont envoyés d'un point A et cette quantité de moustiquaires qui sont reçus aussi d'un point B. Donc, on a aussi introduit tout ce qui nous permettait de faire l'inventaire et le suivi du stock. Donc, on a eu des présentations par rapport à ça, le suivi du stock des ballots, le suivi du stock des moustiquaires individuels. Mais au niveau du Mali, ces 3 outils-là nous a permis quand même de faire la réconciliation entre les quantités qui sont envoyées sur le terrain et les quantités de moustiquaires réellement distribuées sur le terrain. Donc, ça nous a permis en tout cas de faire une triangulation des données afin de nous assurer quand même que les moustiquaires ont été utilisés à bon escient. Donc, en termes de modules, donc, nous avons développé différents modules dans le cadre de la digitalisation. Donc, les premiers modules, c'était tout ce qui concerne les modules de formation. Donc, on a développé des fiches support. Donc, comme je l'ai dit, en 2022, on a commencé la digitalisation. Des leçons ont été tirées par rapport à ces outils de formation, notamment les fiches, qui n'étaient pas très pratiques au niveau communautaire, compte tenu en tout cas du niveau d'études au niveau communautaire. Donc, d'autres stratégies ont été développées, notamment le développement des vidéos en langue française et puis des vidéos aussi en langue locale, permettant en tout cas la compréhension ou l'appréhension de ces outils qui ont été développés au niveau communautaire. Donc, en plus de ces outils, nous avons aussi développé des modules d'évaluation des participants, parce que la formation sur la digitalisation au niveau du Mali s'est faite en cascade, c'est-à-dire qu'on a une formation au niveau national. Ces formateurs-là vont former au niveau régional et au niveau district, qui à leur tour aussi vont former au niveau des aires de santé, et ensuite suiviendra la formation des agents. Donc il était important pour nous d'intégrer ces outils, ou en tout cas de digitaliser ces outils pour pouvoir nous assurer que ces personnes qui sont chargées de faire ces formations en cascade aient la compétence technique et puis la capacité à pouvoir faire cette formation en cascade jusqu'au niveau communautaire afin que nous puissions obtenir les résultats que nous souhaitons. Donc, en plus de ces deux outils, nous avons aussi développé les manuels d'utilisateurs des outils que je viens de mentionner. Donc, ces manuels donnaient en tout cas la possibilité à toute personne, même si vous n'avez pas suivi ces formations en cascade, de voir comment est-ce que chaque outil doit être utilisé ou chaque outil est utilisé exactement pour faire quoi. Et en plus de ces manuels d'utilisateurs, nous avons aussi développé des manuels d'administrateurs qui permettaient aux acteurs à chaque niveau de la pyramide sanitaire de pouvoir prendre en charge ces outils et d'intervenir en cas de besoin. Donc, on a aussi élaboré un manuel d'assistance et cet outil a été élaboré à la suite toujours de 2022 où nous étions à 10 districts. Donc, en cas de problème, au niveau communautaire, on remontait directement au niveau national pour demander de l'appui. Donc, dans ce manuel d'assistance, donc, il était clairement défini qu'en cas de problème, au niveau communautaire, à qui on doit s'adresser, et si jamais on n'arrive pas à résoudre le problème au niveau communautaire, si on doit monter à un niveau N+1, N+2 jusqu'au niveau national. Donc, cela nous a beaucoup permis de pouvoir prendre en charge ou de pouvoir prendre en main le plus rapidement possible les soucis techniques qui étaient sur le terrain. OK. Donc, quelles sont les approches innovantes que nous avons intégrées dans la digitalisation? Donc, déjà, comme je l'ai dit au début de mes propos, la collecte des données se faisait sur du support papier. Mais avec la digitalisation, la collecte se faisait avec des smartphones et ça, depuis le niveau communautaire. Donc, il n'y avait pas, en tout cas, un autre niveau qui interagissait. Donc, c'est les agents d'administration qui enregistraient les informations directement au niveau du smartphone et après synchronisation à chaque niveau de la pyramide sanitaire. Donc, on savait exactement quel est le nombre de ménages qui a été dénombré ou quel est le nombre de ménages qui réellement ont reçu ces moustiquaires. Donc, ça, c'était une innovation qu'on a apportée dans la digitalisation. Nous avons aussi intégré un système de code QR qui permettait d'identifier de façon unique chaque ménage dénombré sur le terrain. Et en fonction du code QR, déjà, nous savons exactement quelle est, ou en tout cas la localité de ces ménages dans le système. Nous avons aussi intégré l'analyse géospatiale qui nous a permis en tout cas de pouvoir voir sur un tableau de bord là où les agents sont en train de faire le dénombrement. C'est-à-dire que sur une carte, on pouvait voir les zones qui sont couvertes. Et s'il y avait des zones non couvertes, les superviseurs pouvaient quand même demander aux agents ou de rediriger ces agents-là dans ces poches qui n'ont pas été visités par les agents. Donc, cela aussi a été une innovation qui nous a permis en tout cas d'obtenir de très bons résultats dans le cadre de la digitalisation. L'autre truc qu'on a intégré, c'était le suivi et l'évaluation en temps réel. Donc, sur un tableau de bord, nous pouvons voir exactement quel est le nombre de ménages que chaque agent a pu dénombrer, que chaque agent a pu distribuer. Et les autres indicateurs aussi qui ont été développés dans le cadre de la digitalisation, il y avait en tout cas cette possibilité de suivi en temps réel par rapport à ces indicateurs développés. Et nous avons aussi intégré un système d'alerte qui nous permettait en tout cas de nous alerter en cas d'incohérence des données collectées au niveau du terrain. Donc ça aussi, ça a été un bon point qui nous a aussi permis de découvrir par exemple les ménages hors normes, par exemple des ménages qui avaient plus de 10 personnes ou des ménages qui avaient plus de 50 personnes. Donc ce système aussi a été très important et nous a permis en tout cas de pouvoir suivre en temps réel les incohérences des données qui remontaient du terrain. Maintenant, voici quelques résultats clés que nous avons pu obtenir de la digitalisation. Donc, sur un total de 1 188 000 ménages qui ont été dénombrés, donc nous avons pu servir 1 168 000 et en termes de ménages distribués, donc sur un total de 6 562 000, nous avons pu distribuer 6 477 000. Donc je vous présente ici quelques résultats en termes de taux. Donc on a pu obtenir un taux de couverture de ménage qui est de 98,17%, un taux de couverture en population de 98,08%, un taux de distribution qui est de 98,85%. Donc, nous avons aussi quelques leçons que nous avons pu tirer de la digitalisation, à commencer par la formation continue des agents. Donc, comme je l'ai dit ici, nous avons pu quand même trouver des moyens pour pouvoir en tout cas améliorer la formation, notamment la formation ou en tout cas le développement des vidéos en langue locale pour faciliter la compréhension des agents, l'optimisation des outils. Donc, étant donné qu'il y a un pré-test qui a été effectué avant le déploiement à l'échelle, donc nous avons pu collecter en tout cas les quelques difficultés que les agents ont pu ou observer dans les outils qui ont été mis à leur disposition afin de les prendre en compte. Et aussi la supervision mixte. Donc, étant donné que nous avons développé des outils pour la supervision, donc les équipes qu'on a pu identifier lors de la formation qui avaient des difficultés, donc ces supervisions-là ont été axées autour de ces équipes et aussi un renforcement des capacités locales. Donc, d'autres leçons apprises, c'est la standardisation des procédures, par exemple, au cas où on doit aller à l'échelle ou intégrer d'autres districts qui n'ont pas commencé la digitalisation. Et il y avait aussi la transparence et la qualité des données et l'amélioration continue, la solution alternative. Donc, comme vous le savez, j'ai dit qu'on a introduit, par exemple, un code QR qui permettait l'identification unique des ménages. Donc, nous nous sommes rendus compte que sur le terrain, en tout cas, il y avait certains ménages qui perdaient ces codes QR. Donc, comme solution alternative, dès le dénombrement, il y a un code ménage qui est automatiquement généré par le système et en plus de porter ce code ménage sur les coupons, l'équipe le mentionnait quelque part au niveau du ménage. Donc, en cas de perte de coupons, quand le ménage amenait en tout cas ce code QR, on avait la possibilité de les retrouver dans le système afin de faire la distribution de moustiquaires. Donc, cette digitalisation ne s'est pas faite aussi sans des défis, notamment l'indisponibilité des réseaux téléphoniques qui a rendu la synchronisation des données en temps réel dans des zones d'accès difficiles. Je viens de le mentionner ici, il y avait quelques ménages qui perdaient des coupons pour la distribution, donc il a fallu quand même qu'on introduise le code ménage pour pouvoir pallier à ce problème. Et aussi, il y avait des problèmes pour la collecte des données en hors connexion, et notamment des gestions de TI, pour qui connaît DHS2. Ça aussi, c'était des difficultés que nous avons pu rencontrer dans la digitalisation. Il y a aussi des limites qui sont liées à DHS2 même et la performance des serveurs. Parce que comme je ne l'ai pas mentionné, nous avons utilisé plus de 8155 téléphones dans le cadre de cette digitalisation. Donc si l'ensemble de ces téléphones se mettait à faire la synchronisation, donc il a fallu quand même que chaque fois qu'on augmentait la capacité des serveurs afin de pouvoir faire face à ces synchronisations multiples. Et il y avait aussi l'inaccessibilité de certaines zones dues à l'inondation. Donc, comme recommandation, étant donné que nous avons pu obtenir, que ce soit la campagne CPS ou que ce soit la campagne moustiquaire, de très bons résultats dans le cadre de la digitalisation, nous recommandons quand même de poursuivre la digitalisation avec les leçons apprises, notamment l'évaluation du processus de la digitalisation qui a été élaboré. Un cabinet a été recruté pour pouvoir en tout cas faire l'évaluation de la digitalisation au Mali. Et aujourd'hui, les résultats de l'évaluation sont disponibles et nous pensons quand même tirer profit des résultats de l'évaluation pour pouvoir améliorer tout ce qui a été fait dans le cadre de la digitalisation. Et l'autre souci, c'est que nous proposons aussi de créer des extensions spécifiques afin d'apporter, ou en tout cas tout ce que DHSD ne permet pas de faire, de trouver des solutions alternatives par rapport à ça et améliorer l'application pour stocker plus efficacement les données et de pouvoir faire la synchronisation des données. Parce qu'au niveau du Mali, nous avons des données de plus de 3 ans. Donc si au niveau des smartphones, on doit stocker toutes ces données, donc souvent ça pose énormément de problèmes. Donc voici ce que je voulais vous présenter. Merci.
Thank you very much for keeping to time. I think we will take one more presentation before the questions so we can go for lunch after the Q&A session. Please kindly keep it to 15 minutes.
Good afternoon, everyone. Bringing greetings from Sierra Leone. My presentation is going to focus on the outcomes and evidence of digitalization campaign that was conducted in my beloved country, Sierra Leone, 2023-2024, a data-driven approach to malaria prevention. Okay, thank you. Well, as for Sierra Leone is endemic everywhere in Sierra Leone. We have 16 districts, and all the districts have malaria. The prevalence is high, but as of now, we are at 12% in one district nationally. And in 2022, death from malaria was 3,151. And the NSCP, our program, thought it fit that we need to do more innovative actions so that at least we deliver our core interventions, and mass campaign is very cost effective, and it will reduce the transmission of the disease. And I want to tell the House that we started distribution of bed nets since 2006 to 2024, and it was paper-based, so we thought it fit now that in 2023 to 2024 we should go digital. So for our campaign, we normally do mass campaign every 3 years, and this was supported by Global Fund, USAPM High, and they bought the 2 type of net. And we used the 2 type of net because it was the data that was given from the vector resistance, insecticide resistance study that we conducted. So we had to make sure that we used 2 types of bed net, the PBO net that was distributed in 7 districts, and the IG2 net was distributed in 9 districts. We have 16 districts in total. And the net were delivered to every household in all the 16 districts. Sorry. So why did we digitalize? We digitalize because we want to make sure that we improve on efficiency, accountability, and accuracy, and want to make sure that we allocate the campaign personnel better in all the districts. And we want to make sure that we have a real-time data, because when you use paper-based, we sometimes have problems in reporting real-time data to take timely decisions and to make sure that we reach the unreached population where they need the bed net most. So by the end of 2024, we had to distribute 4.8 million bed net in all the 16 districts in Sierra Leone. Sorry, I forgot to highlight the challenges that we encounter, but I don't want to label you on that one because paper-based, delay reporting, transparency and accountability, and sometimes it makes the work messy, untidy, so we have to move on to digital because we are now living in a digitalized world. So in collaboration with CRS, because as a program, we didn't do it alone, we worked with our PR, CRS. They had to take over the digitalization process, and we used the Red Rose platform from Nigeria, and they had to make sure that we work with them to ensure that everywhere we digitalize the campaign. And you can see from it, you can see from the board that this was the data flow. We had to use two platforms, two approaches. First, we had to go house to house to make sure that we do house registration using the vouchers, and we use the QR code so that it will be registered, and it took for 10 days. And the other approach was after the household registration, we had to make sure that we distribute the bed nets. In some districts it was 5 days, and in some districts it was 7 days, according to the population distribution. So as you can see, this is how the digital tool, the Android phones, were configured by the Red Rose, and we had to employ ICT4D consultants and assistants to ensure they support us in this whole process. So what was digitalized? Because we want to go innovation, what was digitalized? So first of all, the micro-planning, the training venue, and the warehouse was digitalized. And we want to make sure we track the attendance, because sometimes they are fraudulent attendance, so we digitalize that one also. And the household registration, which was very key, was digitalized. It was configured, because when we do the household registration, we have stopping, if you go to the household and you want to jump over, you cannot until there are mandatory questions and actions that you should do so that you not move ahead if you don't do that one. And again, we digitalize the ITN distribution. We want to make sure that those that need the ITNs access it, have it on time, and use it judiciously. And above also, we want to make sure that the ITNs from the first mile to the last mile, we track it down. So that one was also digitalized from the medical stores to the household level and to the distribution point to the households also. And above all, monitoring and supervision, which was very key, we digitalized it to ensure that effectiveness of the campaign is maintained and timely decisions are taken from the real-time data that we receive from the dashboard. So, what were the outcome of our digitalization campaign that was conducted in 2023-2024 in Sierra Leone? Interestingly, it enabled us to have a real-time data. As I said, the monitor and supervision was digitalized, and through digitalization, we have to visualize on the dashboard the number of household reach, those that were missed, and the vouchers that were distributed, so that at least at the time of redemption, the total number distributed will be redeemed, so that they will have their bed nets. And also, it eliminated fraudulent practices, as I mentioned earlier on, in terms of distribution challenges, because sometimes when we use the paper-based, the community health workers that we normally trusted in to identify households doing distribution, they are the ones that cause fraudulent actions. So, but when we digitalize mobilization, and we have to overcome all those challenges because everything is digitalized. And resource mobilization was also backed by information for pre-positioning, because when we don't digitalize pre-positioning of the bed nets, because sometimes you have to take the bed nets to the distribution point. So after the household registration, we know the number of bed nets that should go particularly to that particular distribution point. So that quantity will be conveyed to that area, so that at least those that have the vouchers, when they get there, they will get their bed net. And above all, during the household registration, the households were told, because we don't want them to go at a far distance, you will not be here at Mozambique and go and collect your bed net somewhere in another town. So during the household registration, they were told where to collect their bed net nearest to their households, so that they will have their bed net in time. Then the outcome also, monitoring and supervision, we are data-driven, and it also allows us to make sure that we provided, as I mentioned earlier on, deployment of the bed net, because when a quantity of bed net is being located at a particular point, the redemption is less. And the vouchers that you use to go and collect the bed net, it is being scanned. So if you have a voucher that is not in the phone, you will not receive your bed net. So that one also enables us to make sure that accountability and transparency is being done. Furthermore, the benefit that we encountered during the digitalization campaign were we had no room for mop-up, although some areas had time to, because some didn't go and redeem their bed net in time because of maybe work schedule or that. So we had to do some mop-up in some areas, so that at least, because when you have the digital, you know that at this particular area, this is the number of persons that should come and collect their bed net. So, but if they don't come, they have to make sure that we do more sensitization, and those that have the vouchers in those particular communities will come and redeem their bed nets. Then again, digitalization, what will benefit? It enables us to make sure we have timely decisions, because during the campaign, we had meetings, daily meetings virtually, and we have district meetings every day, so that when they come back into the field, what the data collectors will look at the data, visualize it, and see where there are areas, so they will take action to those areas that are not covered, or if there are fraudulent practices, they will go and take action to make sure that those things will not occur again. And 17,400 local capacity built-in campaign digitalization health systems were optimized from this our intervention. So we had a coverage, because we set a target that at the end of the campaign we should have a 95% coverage, and at the end of the day we had 92.24% coverage, and we made sure that from the data received, all those that receive the vouchers redeem their bed nets on time. So evidence of impact. So the campaign had evidence of impact by the data received and the dashboards that we use and the maps, because the maps depicted areas that were not accessible, and we had to make sure that to reach those areas, because we wanted universal coverage in every household, 2 persons to 1 bed net. And it also increased coverage and efficiency from the campaign, because when you go digital, those things will be achieved at the end of the day. And also data-driven decision-making was also an evidence, because when you have data on time using the digital tool, you will take action timely to ensure that whatever is going wrong is being addressed timely in a particular community or district. And evidence of impact also, the long-term cost effectiveness by reduction of operational expenses from paper-based printing and logistics. You see, when we use paper-based, also we have some logistical financial issues. So, but when we use digital, we know that this is what we have quantified for, and this is what we are going to do, we are going to use. So that one was also minimized, and we have to maintain efficiency in that area to reduce operational expenses. Then for impact also, sustainability for future ITN campaigns through digitalization solutions and the ease of data access. Because when you go digital for future, because now we are going digital for our next campaign, we know we have the database, so we can make use of that data to plan adequately and correctly for the next campaign. But if it was paper, maybe the paper base will be missing, and there will be some fraudulent actions in that one. But when it is digital, we have a sustainability. We can tap into that data and make sure we planned well for next campaign, where we can distribute the bed nets, those areas that are not have been reached, then we can get there too. And impact also, we after the campaign, during the campaign, we did in-process and end-process monitoring to ensure that what we are doing is of quality, accountability, and transparency. So, and those independent monitors, we are not from the team. They were selected from the universities, and we did a survey to see how efficient, how accountable the process went on. So from there, it was perceived that at least 93% of the respondents appreciated the digital campaign. That enabled us to keep us on track, so that at least we'll maintain our set goals and objectives at the end of the day. So the lessons learned from this campaign was that it strengthened innovation, because we want to make sure that the things that we use, because the innovation was that we digitalize the monitoring and evaluation, the household registration, the ITN distribution, and moreover, the logistics, because that one is very crucial, because if you don't digitalize, that one was the lessons learned, that all the waybills, the quantity of bed net that should go to that particular area, everyone was digitalized. So that was a lessons learned, to make sure that we know the right quantity that should go in the right place at the right time. And data transmission was synchronized at the right time. Although we had some difficulties in network, because as previous speakers have mentioned, in not all the areas in Sierra Leone have data coverage, but you have to make sure you sync the data. So they are given mobile data, but sometimes they use their phones to hotspot, because we want them to sync the data on time, so that we can have a report and discuss on any issue that is being identified in the district. And another lesson learned for future was tracking and reconciliation of well bills. As I mentioned, it was pre-positioned, so we digitalized that one, and complete integration of the digital solutions with the country digital health system. So we want to make sure that we have the district health information system. We are going to make sure we now have incorporated it into national data repository, because as a program, we want to make sure that all our data elements and variables are being captured, so that in future we do make use of all the data for adequate decision making. So we are going to make sure that we incorporate it in our national health information system, so we captured it. So finally, digitalization transformed the ITN campaign in Sierra Leone. It enabled visualization of all the processes that were involved, so that we take adequate information and appreciate interventions by all stakeholders in Sierra Leone. Evidence shows, as I deliberated, that high efficiency, better accountability, and improved coverage was encountered. So we continue investment in digital solutions will enhance malaria prevention and control. So on this note, I want to take a special honor to thank all those that supported, more especially that provided the Net Global Fund, PMI, that supported us, Red Rose, that came in with the tool, that platform was very good because it really placed us on track. And partnership, the Rollback Malaria Partnership, and above all, Alliance for Malaria Prevention, they are with us night and day to ensure that the digital application was well implemented in Sierra Leone. So I want to thank you all for your attention, and may God bless us all.
Thank you very much for that great presentation and sharing Sierra Leone's experience on how you've used Tecta tools to improve your campaigns. I think we had 3 presentations from Kenya, Mali, and Sierra Leone. So we'll take about 5 questions and then we can go for lunch. Please raise your hand, let me see. Okay. Let's start from there. 1, 2, 3, 4, 5. Zanda, you'll be the last. No, let me give it to Somalia. So Zanda, 6. So let's start from Giovanni.
Merci beaucoup. Ma question c'est pour le Mali. Merci beaucoup, Maïga. Je sais qu'au Mali, il y a l'environnement est composé de 2 régions, je dirais. Les régions d'insécurité, comment vous avez fait la digitalisation dans ces régions? Merci.
Number 2.
Hi, I have a couple of questions, one for Mali and one for Sierra Leone. I'll be able to ask the question in French for Mali. Merci beaucoup pour le Mali pour cette présentation, très bien faite. Ma première question, c'est comment les modules de formation ont-ils été adaptés pour répondre aux besoins des participants ayant des niveaux de compétences variés? Parce qu'on sait que parfois, quand on essaie de décentraliser au niveau périphérique, ça peut présenter des challenges. L'autre question, c'est quelles sont les solutions qui ont été mises en place pour gérer la sauvegarde des coupons pour la distribution des milles en l'absence de connexion? Et la dernière, c'est comment les limitations au DHIS2 par rapport à la performance des serveurs ont été surmontées. That was for Mali. For Sierra Leone, so couple of questions too. How was the data flow from Red Rose to Android devices, and then to data visualization tool or storage platforms was monitored to ensure efficiency and timeliness? And last but not least, how did the real-time monitoring through digital data visualization dashboard had improved the oversight of the ITN campaign? And who had access to the dashboard? Thanks.
Number 3.
I think I'm number 3. All right, thank you very much. My question is to the Mali team. It's just on the question on the QR code. So you said at some point you realized that the QR code were missing or lost in those houses, and you introduced household identification numbers. So I want to ask, so going forward, are you still going to be recommending the use of both QR code and household ID, or you are just going to simply stick with what works? And do you know whether there is a bit of maybe resources and terms of time that you can actually save from either going for maybe one or the 2 approaches? Thank you.
Number 4, yes.
Sorry. Thank you. My question is first for Kenya presentation. First of all, congratulate on this solution on using the USSD. I would like to know if there was opportunity to compare these 2 approaches during this implementation, the USSD and the mobile app also. And the second, I would like to know around or regarding the efforts within the malaria program. What was the results that you guys find out involving these two approaches? The second question is for Mali team. I would like to know if the app was also able to support the local language. Since you developed the training videos in local language, I would like to know if there was some kind of match between the videos and the applications. Over.
Number 5.
Yeah, thank you. Wonderful presentations. First is to Kenya. You mentioned missing or unavailable ID cards being a challenge, and the mitigating strategy was to merge households or something of a sort. Is the ID card option the only option that was available, and why did you think of other options for verification? And the second question is to Sierra Leone. One part of it has been asked, the dashboard, who had access, but the other question I want to ask is the capacity that's needed to manage it. Did you have to build capacity? How has it been like building capacity? Because I see a GIS component to it, and you need those special skills. Do you have to build capacity? How easy was it to build and manage capacity, and at the different levels?
The last one to my friend from Somalia.
Thank you. And my question goes directly to Mali. There have been mentioned a lot of digitalization activities, and what I would like to know is that to what extent they have managed to digitalize their services, and what sort of platforms they have been used apart from DHIS2, and how many services of this have been digitalized over?
Thank you. I think we can start from James, Kenya. James, are you online? Or if any of the team from Kenya can respond to that. Yes, James, over to you.
So I will respond to the 2 questions, and then colleagues in the room from Kenya will be able to chip in. So there are 2 questions that were asked to Kenya that I managed to pick up. The first one was on how we compare the use of USSD and mobile app, and how the results compare. So basically, they were all anchored on Digimal, which was the web platform. USSD was the approach of data collection, which was used especially in areas without users without Android devices. They could use the basic phone, which we call Katululu in Kenya. And that meant that even if one did not have a smartphone, they could still be able to undertake the campaign initiative. So the mobile app came in especially for household registration and also for events, because then that meant that you required to have an app to be able to even log into events and to manage the events. So it's mostly for supervisors that came in approach. So the app was used specifically the offline app in areas without network coverage. That is the mobile network coverage where it was weak. And this came in because as a country, we had already deployed the ICHIS platform, which meant that most of the CHPs already had smartphones. And our initial build-up was supposed to use USSD across. But because of those limitations with network, we came up with a mobile app as a stopgap measure, but it's also worked relatively well. The only challenge was the synchronization bit sometimes wasn't as frequent or as seamless as we anticipated. There are some delays in synchronizing data from the app to the Digimal app. especially in the initial stages of implementation of the app. So how we compare the two, our approach would have preferred to use USSD, but we understand the challenges with the network resulting in us pushing towards the app to cover for that particular gap. Then the second question was the unavailability of ID cards, and we said we merged households to be able to ensure that the beneficiaries actually got the net. The way the platform was designed and the requirement is that an ID card was necessary to be able to be registered and also to be able to pick the nets. So it was mandatory to have one. So households that did not have, they were at liberty to either select the person for whom they felt would be used to register them. And that would meant that especially scenarios where we had household headed by minors for whatever reason, either because the parents are deceased or they are not available for that particular time, or for whatever reason household did not have an ID, they would use either the neighbors or the person they would trust most to be able to leverage on that. And what we did do is that we had a data validation process post the registration, which took 2 days. And that meant the teams would review the records and verify if the numbers were correct. And then for certain instances where numbers will be in outliers, then that was verified and ascertained that they were true, that the houses were merged, then they would still proceed to have the nets being issued. I want to bring it to the Kenyan team in the room to be able to add something.
We will let the others respond. Thank you. So maybe Celion, one. Yes.
Thank you very much. I didn't want to go in detail because some speakers we are talking about the processes, because I was allocated only 15 minutes. But now, at least, I will elaborate on that one now. You see, for data security and efficiency, we have to make sure that those that handle data are secure the data. Not every person will handle the data. So as I mentioned in my presentation from Red Rose, they were the ones that handle the data, and CRS took the main part because we had 4 subcommittees, the digitalized committee, wherein CRS was in care of all the phones and the digitalization process. So the data dashboard was handled by the Red Rose and CRS. They enter into the dashboard to ensure that the data, when we meet, they give an overview of what's going wrong in a particular area. And also we had data managers that were trained to handle the data at all the 16 levels to ensure that at the end of each day, they give an oversight of what's going on in the district. And we trained the ICT4D guys. We have the manager of CRS, but the assistants we are trained so that they support the district in 2 per district in all the 16 districts where there are troubleshooting issues. They go and act there immediately. But access to the dashboard was by CRS and Red Rose. And I think that's it.
Yes. So maybe to Mali, you had a lot of questions.
Oui. Merci beaucoup. Je vais commencer par la question de Giovanni, qui était de savoir comment est-ce que nous avons fait la digitalisation dans les régions du Nord. Il faut comprendre déjà que dans le nord du Mali, à cause de l'insécurité, la digitalisation n'a pas pu être menée dans les régions du Nord, comme vous avez vu aussi dans notre première présentation. Même là-bas, c'est la stratégie communautaire qui a été adoptée à cause de l'insécurité. Donc le nord du Mali n'a pas été concerné par la digitalisation. Maintenant, la deuxième question, c'était l'adaptation des modules de formation. Donc par rapport à ça, déjà dès la phase pilote ou dès la phase terrain, nous avons pris en compte les retours sur le terrain déjà pour alléger les applications qui, de surcroît, aussi vont avoir un impact aussi sur les modules de formation. Donc, en plus de ces modules de formation, nous nous sommes rendus compte que au niveau communautaire, c'est plus facile pour les agents d'administration de regarder les vidéos pour mieux comprendre les outils que les supports numériques qu'on mettait à leur disposition. Donc ça, ce sont des adaptations que nous avons pu apporter par rapport aux modules de formation pour faciliter la compréhension à tous les niveaux du pyramide sanitaire. Maintenant, concernant la question solution des coupons en mode hors connexion, il faut savoir déjà que la plateforme que nous avons utilisée, c'est DHS2. Au niveau des smartphones, c'est DHS2 Capture que nous avons utilisé. Et ça, c'est une application qui fonctionne en mode hors-line. Donc, les comptes pour le dénombrement et les comptes pour la distribution sont différents. Donc, au début de la distribution, dès que l'agent va se connecter avec son compte de distribution, la totalité des ménages dénombrés au niveau de l'aire de santé est synchronisée sur les smartphones, permettant à l'agent de pouvoir travailler même en mode hors connexion. Donc ça, c'était déjà la réponse à cette question. Concernant la capacité du serveur, dès 2022, la stratégie que nous avons adoptée, nous avons séparé notre serveur web et notre serveur database. Serveur web uniquement pour tout ce qui concerne la visualisation des données et le serveur database pour tout ce qui concerne en tout cas la réception des données, l'analyse des données. Donc ce qui faisait que on avait en tout cas l'équilibrage des charges entre les deux serveurs qui nous permettait d'avancer sans problème avec la campagne. Maintenant, au début, nous avons commencé avec une certaine capacité de serveur qui s'est retrouvée doublée à la fin de la campagne. Donc, voici les alternatives que nous avons pu apporter par rapport à cette question de serveur. Donc, à chaque fois que les problèmes se posaient, on augmentait un peu la capacité du serveur pour ne payer que ce qu'on a réellement besoin. Donc, concernant la question code QR ménage, donc en réalité, au niveau du Mali, on avait 3 possibilités pour retrouver les ménages. Il y a le système code QR qui était disponible sur le coupon. Nous avions aussi le numéro du téléphone du gardien d'enfant qui était aussi un numéro unique, mais on s'est vite rendu compte qu'au niveau communautaire, les ménages n'avaient pas forcément un téléphone, ce qui faisait qu'en cas de perte de coupon, on n'a aucune alternative pour pouvoir retrouver le ménage. C'est ce qui nous a amené maintenant à introduire ce code ménage qui est automatiquement généré par le système en dénombrant un ménage. Donc non seulement ce code ménage va être porté sur le coupon par l'agent, il le portera aussi quelque part au niveau du ménage. Donc en cas de perte du coupon, le ménage pouvait amener ce code ménage sur les sites de distribution qui nous permettaient de les retrouver et de faire la distribution. Donc d'ailleurs, c'est ce qui a fait qu'on a pu atteindre ces taux de distribution. Maintenant, concernant la question langue locale, c'est vrai que nous avons développé les applications en français. Nous avons aussi développé les applications en langue locale pour faciliter la compréhension, mais l'application n'était pas en bambara. Donc soit c'est en anglais, soit c'est en français. Comme c'est les agents de toutes les façons qui ont un certain niveau, donc ils pouvaient utiliser l'application sans pour autant que cela soit traduit forcément en langue locale. Maintenant, concernant les services et les plateformes utilisées, au niveau du Mali, c'est DHS2 que nous avons utilisé pour toutes les campagnes. Et les services qui sont digitalisés, tout ce qui concerne la campagne CPS, l'enregistrement, le traitement des enfants, le suivi, gestion des médicaments, la supervision, ça a été digitalisé. Au niveau de la campagne MILDA, je viens de mentionner les outils que nous avons digitalisés. Et en plus de ça, la supervision à tous les niveaux, niveau national, régional, district, aire de santé, tout ça, c'est digitalisé au niveau du Mali. Et cette année, nous avons aussi digitalisé l'enquête LQAS et le tout s'est fait sur une même plateforme qui est le DHSD et ça nous permettait de faire une analyse croisée entre ces différentes campagnes. Donc je pense que ce sont des questions qui ont été adressées au Mali. Je ne sais pas si j'ai omis des questions. Merci à vous.
Thank you very much. I think you've addressed all the questions and I think in the interest of time, you have the country reps here. You can always interact with them during lunch or any of the breaks. There are a few questions in the chat for online participants. The presenters will address them in the chat for you. So let's appreciate the countries that have presented. Please, let's appreciate them. Thank you so much for this wonderful presentation, and also thank you for participants for these wonderful questions. We go for our lunch. We are supposed to be back at 2, so please kindly ensure to be back at 2 so we can continue the next session. Whilst you are going, there's a QR code on the screen. This is for tomorrow's session. Tomorrow we have a workshop in the afternoon to look at 4 main topics. There's the first one on bring your own device. There's one on campaign integration. There's another one on digital payments, and there's a last one on reuse of data or data use. So kindly scan it and select the option to allow us to be able to allocate the rooms that we have these workshops. So these workshops will run similar to what we did yesterday. For those of you who are here, there will be technical sessions for us to discuss on some of the key issues that we are seeing or discussing here. So until then, I think we can all go for lunch and come back at 2. Thank you.
This afternoon session is just introduce Fatimata. So Fatimata is the ITN focal point with Nigeria NMEP, and she's going to be chairing the rest of today's session. So Fatimata, welcome, and I'll hand over the microphone to you. That's the flicker. Sorry, it's actually Fatima. It's Fatima. And that's the flicker there, okay? So first speaker's ready, so you can invite them to come up.
Okay. Hi, good afternoon, everyone, and welcome back from lunch. Good afternoon. Yeah, the food was that good? Yeah? All right, so welcome to the after lunch session. I hope it wasn't too heavy, that we're awake to sit through this. So it's a continuation of the theme 2, outcomes and evidence of digitization. So as you all know, integration and digitization is a key component to consider now, especially considering the limited resources that we have. Digitization and integration has shown to improve effectiveness, efficiency, and excellent in cutting down cost, providing a common platform and data source where different health interventions can key into. So we're going to hear from different countries, their experiences, and what lessons they've learned. So with that, I would like to invite the first speaker, Mariana da Silva from the NMEP in Mozambique. Can we give her a round of applause, please? Okay. The next speaker is Gombo Yakubu from NTD, Nigeria. He is joining us virtually. Yeah, I see him online, so let's welcome him as well. Okay, so, ready? Yeah? All right, so I'll hand over to Mariana.
How this works? Thank you. Thank you. Boa tarde. Thank you for the opportunity to share Mozambique's experience in implementing multiple campaigns through a common platform at the Ministry of Health. I'm going to start with a brief background for Mozambique. So, malaria in the country, according to WHO, occurs on 3.5 in Mozambique. So Mozambique are in 5th place in terms of the total worldwide malaria cases reported. According to the routine data in the country, the incidence is around 275 per thousand. So in response to this burden of disease in the country, a variety of prevention and vector control are being implemented through the mass campaigns. As you can see in this map, we have different vector control in different provinces. So this is along all the 10 out of 11 provinces in the country. So all these campaigns have gradually been digitized. We started digitalization with MDA in one province in the northern part of the country as an emergency response. This was in 2020. And we used Survey CTO, and the visualization was through Power BI. Following this campaign, we implemented in large scale in 9 provinces out of 11, the ITN distribution, which was the first one digitized in this proportion. So for that, we used DHIS2 in 7 provinces, and then we used Salama in two provinces. As I mentioned before, in 2020, we used Survey CTO, and in 2022-23, we used DHIS2 and Salama. So after this experience using these multiple digital tools, in 2024, the NMCP decided to use an integrated system to conduct the following campaigns. This is when we decided to use, again, Salama in 2024 with SMC campaign, first one be digitizing, and then the IRS in the cycle of 2024-2025. So what is Salama? Salama is a Mozambique customization of the Digit HCM by Eagle Foundation, in which the 3 main modules help us to run the campaign in the more efficiently than the other tools that we used before. So it was possible to collect data through the mobile. We customized specific dashboards, and also the management tools were included in this platform. So until now, we used Salama with 3 different campaigns. We use it to SMC, we use it to ITN, and also we use it to IRS. So it's important to highlight that in this first quarter, we are using simultaneously in these three campaigns the same tool. So in terms of the highest number of users that we had at the same time, it was approximately 7,000, and in terms of the population protected so far, it's more than 3.6 million. All the implementation that we are conducting in the country, it's accompanied with a process of evaluation. So we are not only implementing, but at the same time we are doing some kind of evaluation. So the main source of data for all these evaluations are the programmatic malaria data. We are using the operational campaign data. We also made some key informant and users interviews, and we are conducting post-campaign household surveys to assess how best we are in terms of the results or impact of all these campaigns. Now I'm going to share with you a few results. We want to start it with how we improved the usage of data in real time So during the campaign, it was possible to make important decisions when we found out that the specific days that were defined at the beginning of the campaign wasn't enough to cover all the districts and achieve the targets that we set. So it was possible to identify specific areas where the team could go and implement the campaign, and this resulted in a good coverage at the end of campaign. So initially it was planned for 5 days, but we ended up to have 1 or 2 more extra days. So although it is a kind of a decision that could be made without a platform, but we felt that the possibility of seeing in real time or near real time the specific areas where we could prioritize, this was a result of the digitization. We also assess how the users were feeling about this platform. So the evaluations show that the digitization has been very well received by all the users and even for the decision makers. We started the evaluation with ITN, but here we are showing the results, the specific results of SMC campaign in terms of general experience, if it was easy to use or not, if they felt confident in terms of using the platform. And also, we did some kind of comparison between the tool and the paper format, and we received a very good feedback for both. For the coverage, we also did assessment after the ITN campaign and also after the SMC campaign. So after the time of the campaign, we had a very high coverage, mostly 100% and more than 100%. And the survey showed us that the coverage was high, not that high, but high, and also for ITN and also for SMC. So we found that it is possible to achieve, and the platform doesn't impact it in the way of it was impossible to achieve the targets. We also assessed the missed areas. So we tried to combine all the GPS points that we collected during the campaign, also using the grid tree, and trying to evaluate the proportion of the missed areas during the campaign and how this missed area impacted in the coverage that we achieved during the campaign. So after this exercise, we found that approximately 42% were found that not have been visited during the campaign, but the comparison in terms of the population layer revealed that only 4% of population was mapped to these inhabited areas. So this doesn't make a lot of difference in terms of the coverage that we achieved during the campaign. So we were satisfied seeing that the missed areas doesn't mean a lot of population missed too. In terms of the impact, we started after the campaign, we continued to monitoring the incidents, and it was specific for the immediately 12 months after the campaign. And we used ARIMA modeling to assess how the incidents were reported if we are considering a scenario with no ITN or with ITNs. So we ended up seeing that at least for 3 provinces, no differences were verified after the campaign. But the other 6 provinces, we saw a huge impact in terms of reduction. We have here the listed provinces where we found a considerable reduction. The lowest reduction observed was about 25%, and the highest was 85% in the southern province called Gaza. So the model also suggests that over 4 million malaria cases were averted through the mass campaign here following the implementation. In terms of the cost, so the transition from paper to digital, of course, require an initial capital investment. So although some assets that we identify later that could be reused in the future campaigns. So taking in account this integrated approach that was defined by NMCP, we could attribute it to the different campaign, a specific proportion in terms of what was expected to be removed. And we started with initial investment in around $4.2 million US. And after we removed the percentage that we attributed specific for ITN, we ended up with a final estimation in terms of in about 3.3 million of US dollar. So we also did the comparison in terms of the system. Yeah, we also did the comparison in terms of the total cost of the campaign through paper versus digital from 2016 to 2022. And we saw an increase on about 32%. However, when we adjusted all this percentage, according to the inflation, we saw a decrease of 5.6% in observed instead of the initial 32. So we want to highlight that the huge difference that we saw on the paper format versus digital format was related to the trainings and all the M&E component that made the digitization costing more in comparison to the paper format. So because the NMCP decided to implement this integrated approach, we believe that the recurrent cost incurred as a part of digitalization can reduce if we are using the same platform across several campaigns. So in specific, we believe that if we are using the same platform, we can reduce the training time, having fewer days required for example, a central master TOT and provincial training. And we also have a specific experience during this year where we didn't had the need to conduct the central TOT because we are using the same personnel, and we are assuming that the The capacity is already built, so the master TOT was no needed. And this is related to the efficiency because the teams are more and more familiar with the previous campaigns, and the needs of trainings are reducing over the time. We also think that we can have cost saving in the micro-planning process because all the digitization enables data capture and validation in Salama, including a micro-plan module. So this can reduce in-person meetings or workshop costs. It is also possible to optimize the resource use with this potential of integrating different campaigns such ITN and SMC. We didn't move in that direction yet, but we identified as a next step possible to achieve. And also, it is possible to reduce the technical support needs once the local team has more experience in conducting independently from the central level people in each steps of the cascade of training. So apart from the programmatic area, we also developed the payment module. It is not yet in use in the actual campaigns, but we started to use the attendance module as a way of improving all the availability of documentation needed to make the payment. So the idea is to use in the next campaign also the module to manage all the payments in the field. Not always went 100% good. We faced some challenges. I want to mention a specific challenge regarding to the supply chain, the IT and supply chain. We didn't manage to capture all the movements of nets. It was between 21 to 44% of ITNs that were not reported during the campaign. So this made a significant blind spot for us during the campaign. So we planned to improve some functionalities in the platform, which is including a scan functionality and also to our stock auto-populate functionality to allow more efficiently tracking of these nets, apart from all the register that is being made from the principal warehouse until the team's distribution. For SMC, we also faced a challenge in terms of tracking individuals in each cycle. In the first campaign, we only managed to track about 7% of children in the following cycles, but improvements on the platforms have been made to ensure that in the next implementation we can perform well. So these improvements versus in terms of having a unique identifiers through the platform, including approximate search functionality, and also focus on reuse of data during the trainings with the teams. In terms of the next steps, we capture a lot of data We have GPS points, we have all the households visited with all these campaigns. So the idea is to have to compile all this information and have collaboration with the other sectors of the government to create a common geo-register that can be reused in the future process of micro-planning of all the health campaigns, and can be also available to the other ministers to use when they plan to conduct activities at the community level. And also, we think that we can optimize all the management that is in place to the digital tool. We think that it is possible to make improvement through the iteration. So all the iteration could be informed by inclusion of new data source and modules, to trial the error of system process, to have post-implementation user feedback, and also to strengthen the use of data. And to ensure that we have a long-term sustainability at the Ministry of Health, trainings are being organized, and the focus is on the NMCP and MNE staff, and also the collaboration with the specific departments at the Ministry of Health, which are responsible for the information system and also for the technology system, namely DISH and the TIC. And all this work was only possible because of all the listed here. So at this stage, we want to thank to all the partners who supported the development and the implementation and the continuous strengthening of digitalization in Mozambique. Thank you.
Okay, thank you very much, Silva. I think we can go straight to the next presentation online by Gambo Yakubu. I'm trying to find it. Okay. So while we try to link up with the presentation, just to highlight Mariana's presentation about implementing different campaigns within one platform, which is very efficient and effective. The ability to reduce costs when different campaigns on the same platform, there will be no need for intensive micro planning. And also to appreciate the challenges they had with the IT and logistics, SMC cohort tracking in terms of retrieval and tracking the children across different circles. And we look forward to their plans of a consolidated master data set. Okay, I think we're ready with Gambo. Mr. Gambo, can you hear us?
Good afternoon, everyone. My name is Mr. Gambo Yakubu. I'm the head MIE, Neglected Typical Disease Control Elimination and Eradication Program for Social Welfare Nigeria. I'll be presenting an integrated platform for health campaign digitization, that is Nigerian disease SCM implementation. This presentation will showcase our effort to enhance efficiency and effectiveness of health campaign through digitization, particularly focusing on our experience implementing the GDS SCM tools in Kano State. Kano is the most populated state in Nigeria, with almost 20 million people spread across 44 local government areas, that is districts. Due to its large population and significant disease burden, the state conduct various health interventions campaign aimed at improving health outcomes. This campaign include mass administration of medicine against lymphatic filariasis, onchocerciasis, soil transmitted helminths, and schistosomiasis. We also conduct maternal, newborn, and child health weeks, LNIs for malaria and prevention, LNI for malaria prevention, seasonal malaria prevention, polio and non-polio SIs such as measles, yellow fever, meningitis, campaign, and azithromycin MDA, among others. Despite success achieved, several challenges have been faced. The most prominent includes fragmented campaigns, where different healthcare programs operate independently, leading to duplication data collection, inefficient micro-planning, and redundant household visits. Additionally, there is limited local stakeholders' engagement in the planning process and minimal government involvement in developing and implementing digital tools and mining ownership and their sustainability. Furthermore, the fragmented campaign is managed in silos, making it difficult to integrate into a central repository, thus limiting government visibility and real-time monitoring of health intervention. So I would say, way of introduction to address these challenges, we implement the e-government foundation DGHCM tools with support from CHAI and Federal Ministry of Health and Social Welfare. The objective was to digitize and integrate major campaign components through an end-to-end digitization approach. From August 2024 to February 2025, the DGHCM tools were piloted across at LGS in Kano State. This pilot featured an incremental increase in both geographic and the technological functionalities. In the initial phase, we focused on beneficiary registration, household delivery, stock tracking, and dashboard monitoring. As we expanded, we introduced models for beneficiary ID generation, school-based delivery, supervision, complaints handling, and human resource management system functionalities. Ultimately, we targeted about 640,000 people across the NDGA, which included specific mass drug administration campaign for lymphatic filariasis and schistosomiasis. So the implementation committee, that is in terms of the project, the GHCM tool was coordinated by the State Ministry of Health, led inter-program campaign digitization team. This team was established to provide strategic, operational, and technical leadership throughout the implementation process. The team was structured into three: technical team led by the incident manager of the Emergency Operations Center, EOC, which provided technical oversight and coordinated data and IT-related activities. Then we have also the strategic team led by the Director of Public Health of the Ministry of Health and responsible providing overall guidance and direction. Then there's also a steering committee led by the Honorable Commissioner for Health, comprising of the high-level stakeholders such as Head of Health MDAs and directors from the Ministry of Health,
as well as various program managers, ensuring this is ensure
alignment with broader of the health objectives. And operations and health desk stationed at EOC to address also technical and operational challenges and provide on-the-ground support was also established. By building local capacity through training and technology assistance, that is DA, at both the facility and NGA level, we aim to ensure sustainability by empowering existing staff to provide support without relying on external support. Now, government-led implementation. So we adopted a government-led approach to implementation of DGHCM tool, ensuring overall and that local capacity was built at the facility level for sustainability. 4 levels support was established, driven by the technical team. There's what is called facility TTS, that the health facility staff serving as frontline support and supervisor to community the directed distributors, that CDDs, as on technical issues and training. Then there's local government TTH deployed to provide the oversight and serve as the first line support when issues could not be resolved at the facility level. Operational Health Desk team provided centralized support and coordination from the state EOC. Then there's also DPS, Statements of Health and Incident Manager EOC, which also provided strategic oversight, coordinated data review meetings, and ensure alignment with broader health objectives. The multi-layered approach was designed to enhance local capacity, local ownership, reduce reliance on costly ad hoc support, and promote sustainability. Now looking at data use example from TOFA, a practical example of data use from digitization comes from Langelwort in Tofa local government during the MAP campaign. Initially, the 1 and 2 show low coverage despite high reporting from the ECDD through real-time data monitoring provided by the dashboard. This gap was identified, which prompted an immediate corrective action by recruiting 7 additional CDDs. This additional CDD began reporting by the 3, contributing to 33% of overall records submitted for Langelwort. As a result, coverage improved to 80% by close of the campaign, compared to 86% for Tofa. Without the contribution of this additional, the Langel could have been falling below the expected coverage threshold of 65%. This demonstrates real-time data can empower rapid, informed decision-making, use case that was never before possible in the NDA program. So in terms of the planning, one of the achievements is another key achievement in improvement in drug accountability during and after the MDA, where CD are tracked and monitored by a triangulation of service delivery and MIE data during the campaign. It was evident that previous campaign have witnessed drug wastages due to poor tracking and monitoring of stock, while reverse logistics has been a major challenge due to lack of visibility into the MDS. A particular CDDs in Tofa was traced and observed to have discarded quantity of drugs after a day's work. This tracking mechanism improved drug accountability and preventing wastage with CDD returning drug after every day's work, as seen in the graph. Then in terms of also achievement again here is, one of the most important achievement of this implementation has been the creation of a comprehensive registry of household, schools, and individuals across the targeted LGS. Through door-to-door enumeration, a registry was developed comprising 71,120 households, 800 schools, and this 507,136 people. This registry serves as a reliable and reusable population data source for future health campaigns. Additionally, geo-reference household, list, gender, and ages aggregated population data were collected, enhancing our ability to plan targeted intervention. The availability of accurate population data ensure that subsequent campaign planning, monitoring, and evaluation can be based on reliable information, improving overall campaign effectiveness. Now, in terms of coverage outcome for schistosomiasis MD, during the February 2025 schistosomiasis implementation, a total of 446,804 people were treated across 8 LGS over a 5-day period. The campaign achieved an average coverage of 85%, which is significantly above the minimum threshold of 75%. This outcome demonstrates the efficiency and effectiveness of using a digitized approach to planning, implementation, and monitoring. As shown in the coverage graph, all the LGS achieve coverage above the required threshold, highlighting the strength of the integrated digital approach. Then on the aspect of the LF pilot coverage outcomes, Tofa local government, where the GHCM for the 2024 LF MDA campaign was piloted, achieved the highest coverage in the entire country, accounting for the LF coverage evaluation survey conducted by the Federal Ministry of Health and Social Welfare. The reported coverage for Tofa was 97%, which is approximately 30% points higher than the 2 other LG and its size surveyed in Kano. This outstanding result underscored the impact of digitization in improving MDA outcomes. The high coverage in Tofa was directly attributable to improved data use effort, as the real-time and granular data available through the dashboard allowed for better planning, monitoring, and responsive decision-making. In contrast, the undecided LGS had much lower coverage, highlighting the benefit of a digitized approach. Cost saving due to economies of scale. Beyond improving coverage and efficiency, digitization also contributed to significant cost saving due to economies of scale. Despite a 239% increase in the number of users, costs rose by 88%. This demonstrates how scaling the implementation across the multiple LGA helped distribute expenses more efficiently, resulting in lower per unit cost. The total implementation cost by LGA when deployed at scale was approximately $9,167. This represents a significant reduction compared to standalone cost of $39,000 per LG in Tofa local government during 2024 pilot. The cost reduction achieved by spreading costs across a larger user base and by leveraging the shared resources, which is a critical advantage of a scalable digitized system. Cost-benefit analysis. So on the aspect of the initial cost of digitization was higher per person treated compared to the paper-based method. However, when the factor in the ability of digitization to prevent extra rounds of MDA and avoid miscellaneous surveys, the cost became comparable to, or even lower than the traditional paper method. For instance, achieving a 20% coverage improvement in digitized MDAs over paper-based campaign ensure that rapid coverage threshold were met without requiring extra round. This is achieved through the improvement in the data quality, usability, and use of proactive and active decision making to boost performance and ensure all eligible population are reached, as we have seen in the previous slides. This improved reach of service through digitization that prevent the need for redundant campaign by ensuring proper timing of transmission assessment survey, further reduce costs in the long run. Ultimately, digitization offers both direct and indirect cost benefit by enhancing efficiency, accuracy, and coverage. So the lesson learned here is, and also based on the next step, is following the highlighted success recorded in both LF, lymphatic filariasis, and schistosomiasis MAM in Kano, the Ministry of Health and Healthcare Management Board, in collaboration with CHA and e-Government Foundation, have commenced preparation to roll out the GTHCM tool in a polio campaign exercise. This will begin with polio shadowing in the forthcoming April 2025 polio campaign, followed by development and customization of DGHCM tool to fit our needs and also peculiarities, and subsequently roll out the tool in May 2025. So, as in conclusion, I must graciously thank everybody for the attention, and I hope this presentation has provided a valuable insight in the implementation of DGHCM tool in Kano and how it has attributed improving health campaign efficiency and effectiveness. I'll be very happy to take questions or discussion specific aspect of implementation for that. Thank you so much for listening.
A great job in highlighting how in Nigeria we have so many different campaigns, but they are running on different platforms and they need to integrate them. And we have seen some great achievements that emphasizes the benefit of digitization in terms of visibility and cost savings and higher coverage and so forth. So it's now open for question and answers. If you have a question, put your hand up for us. Okay, we have 1, 2. Any more? 3, 4. Okay, so I think we can start with the first 4. Who was 1? Yeah, there. There you are. All right, go ahead.
The question is to Mozambique on the cost effectiveness in terms of saving between the paper and the digital. What are the key cost centers we can benchmark or run from in the analysis between the paper and the digital process? Then 2, in the analysis for the savings between the paper and the digital, did you also consider the non-monetary areas like time, ITE, technical people against the non-technical people that are using the paper, so that we can have the true picture about the savings you are trying to compare? Thank you.
Thank you. I think we can take all the questions, then we respond. Number 2.
Okay, thank you very much. I think my question is to our colleagues from Mozambique. Okay. I would want us to maybe just go back to the slide on the cost of implementation, if it's possible. IT? Yeah, so we can see that the recurring cost is 3.12 million. And with this, I think I have 3 questions in line with this. So first, is the recurring cost is it a yearly recurring cost? So if I hear the word, recurring, I'll assume that it's a yearly cost, or if there is like a defined period, I think it would be good to really just know what that is. The second is 2.61 million was for digital trainings. And my second question would be, in a campaign, right, you typically have like trainings that are to be done, even if you're using like digitalization and paper. So, in the context of utilizing 2.61 million on digital trainings, are these like, a separate thread of trainings that have to be conducted, or is it like the whole cost of both, digitalization training and the regular training? My third question on this as well is looking at the cost of the training. What were the cost drivers in the training? Is it like per diems? Is it, it would be good to kind of just have an insight on why this cost is, as high as it is. I think, I'm just expressing my, surprise, because 3.12 million, I think this is the highest I've seen in a digitalization budget so far. Then my fourth question will be, now that you have digitalized and you have like resources and so on, how is digitalization now going to help you to reduce costs? In your final slide, I think you had mentioned a few things around like integrating the data and reducing. I think my point would be, are there like elements of waste or, elements of opportunities to improve, the expenditures that you have identified? Thank you.
Thank you. Number 3. You got them?
My question is also for Mozambique, and it is on the supply chain. Really interesting to see the share of nets scanned at each level. The interesting thing was that we were down to 57% at the level before the household, but then we jumped up to 82% at the household. Can you explain what was happening at each level, and then how we got a much higher share when it was dispatched to the household? And then also, if you made any efforts to track what those remaining 18% of nets were. Thank you. Over.
Thank you. Do you want him to repeat it? Yeah. Okay. Could you repeat the question again, please? Yeah.
If we can go back one slide. Or ahead. So there was a graph that showed share when we got to the problems. There was a graph that showed the share of nets scanned at each level in the supply chain. And it started with 100% when there was intake into the district warehouse, and then it reduced at each level. The level before the dispatch to the household, we had got down to only 57% of the nets being scanned. But then when we dispatched it to the household, we jumped up. So there we go. This blue bar. So in the team leader, we were tracking only 57% of the original nets. But then when we dispatched to household, we tracked 82%. So what do you think was happening physically in that process? And then the last part of that question is, we only scanned 82% of the original nets. Did you make an effort to track what happened to the remaining 18%? But I also want to say this presentation was amazing, like really, really good work.
Okay, thank you. Question number 4.
Yeah, thanks so much. So my question goes to Nigeria. So first one is, what specific improvement in drug availability were observed after the implementation of the Digit HCM tool in TOFA LGAs? And the second one is, how does this multi-level support structure ensure longer-term sustainability for health digitization campaign? But by the way, you know, the the Mozambique presentation was amazing, really. Thanks so much.
Thank you. Oh, Robert, you're a bit late, but we'll let you ask your question.
Thank you. So thanks again to the team, and especially also to the Nigeria team for that presentation. My question goes to the Nigeria team. In terms of the cost analysis, it's very interesting to see that you had that detailed cost analysis, and I think your result shows that digitalization is actually cheaper as compared to using the paper-based tool. I just want to understand, because what we've been made to understand, especially when you are doing the first time, is that it's quite high because of the investment that you made. But this was your first time, and yet it was way cheaper as compared to doing the paper-based. Are there any factors that contributed to this? Over.
Okay, thank you. I think we'll start with Mozambique. You wanted the first question to be repeated, right? Oh, you got it.
I can start from the last and then.
Okay, so go ahead.
Thank you for the comments, and thank you for the questions. I have colleagues here from Mozambique, so I want to invite them to respond if they want to. I will start responding the last question, because we have here the slide. The first thing is that we had, this is a result of triangulation at the end of, during and at the end of the campaign. So we had different people involved in different stage. And starting from the district warehouse, where the satellite warehouse is the one who is close to the communities, the responsible to register the nets was someone allocated specific for the days during when the team were distributing at the specific village. So we have different actors, each one with their own dashboard on the mobile, but the challenge here was at the beginning we didn't have the district warehouse, for example, didn't have access to what is happening in real time in the other points of where the nets were kept. So this is one challenge that we, in the following steps, we identify as the need to correct. And then the interesting part is we have we have lots of or less of adherence to the guidelines in terms of each role, what they should do at the beginning of the day, keeping the register, what is being delivered to the teams, and at the end of the day, doing the register, what was coming back to the field. So when we go to the teams, the only information that we collected was how many nets were distributed. So we triangulated that to understand which group or which person has more difficult in terms of reporting all the things that happen in his specific level. So that's why this difference. So we distributed 15,000 nets. This is in accordance to the initial stocks that we are saying that we are not we didn't distribute 100% of the total nets that we had at the beginning. We are comfortable in terms of the people who actually received the nets, but we need to improve accountability on the intermediate stage. So that's why we think if we can implement scanning at the lowest level, even for each point where the nets are previous to go to the field, we can triangulate it more and do the comparison, what the teams are reporting and what the scan say to us. So we noticed that they had challenge because of the dynamic of the activities during the day to capture all the register while they are doing the activities. At the end of the campaign, of course, we went back to understand what happens with the other nets, it was stolen or what exactly happened. But the good news is the difference between what was in the first warehouse and what was said that was distributed is not that huge. In terms of the cost drivers, first, how we attributed, we removed the specific days during the duration of the training. So the training was 5 days, which the digital part was only 1.5 days. So what we did was to have the total cost of the training and then disaggregating the costs for 1.5 days, specific for digit part and M&E system. And yes, the drivers of the higher cost was the per diem. Yes, this is the one of who contributed more on this total cost. And when we are saying that we can improve is because, as I mentioned during the presentation, the people involved are the same, at least at the central, provincial, and district level, and they already have the capacity to conduct this training. So there is no need to convene the same steps that we did at the beginning of the digitization. So the knowledge is already there. That's why we are saying that we can save money through this channel. And how we calculated the 19% attributed, for example, for ITN and SMC and IRS, it wasn't by year, it was specific to the cycle that we are planning to implement. If it's three years implementation, then we attributed this 3 years, ITNs and SMC, the time according to the periodicity that each campaign are conducted in the specific grant available. And I think I missed the first question. If it's possible to repeat. It's a cycle of campaign, not 1 year. If it's ITN, we're implementing ITN in 2.5 years. So it is recurring according to the periodicity of implementation of the campaign.
Question 1, if you want to kindly repeat the question, she didn't get it. Yeah.
She answered question 1 because we just wanted to know what the drivers in the analysis of the cost savings between the digital and the paper.
Yeah, you already answered it.
Oh, okay.
Okay, thank you very much. Mr. Gumbo, you had 2 questions. If you can respond to them, please.
Thank you so much, Fatima, my colleague in office, and then thank you, the participant in this important meeting, the MP. Let me first of all apologize for due to the poor quality of some segment of my coverage, but nevertheless, it's well noted, and at the same time, in terms of the question asked, the first question was something around drug availability in one of the LGA that we have pilot tested the digital SCM. That is so far. I know the reason why he actually asked that question because he saw 97% coverage, which if you look at it for the LF, the coverage threshold should be 65 to 80. Actually, it's actually not an epidemiological coverage, but rather a program coverage. That's why you are seeing that 97%. So that's the clarity on that one. And then in terms of multi-level support, you see, one thing that you should understand is if you are talking about digitization, neglected typical disease program is actually amateur when you compare with malaria and vector elimination program. Because we actually leverage on malaria at all levels of the support, especially in Kano State, where at each time, right from the micro planning, we try to ensure that every stakeholder is engaged so that we can get all the needed support and ensure the implementation happen the way it should be. And that's why we're able to see such that kind of changes that we can see in the project. So that. Then in terms of the cost analysis compared with the paper base, it is crystal clear that whatever you are going to start at the beginning, you must do a lot of investment, and that's why the cost is very high. And that's the reason why subsequent one, you see the reduction in terms of cost because there are some things that you don't need to even go into. So I think that's the reason why. So what is the CH1 is the higher, the more you expand, the less the cost. And that's what we are learning from there. And I believe we are also improve on that when we upscale to other states in the country. Thank you so much.
Hi. Welcome back from tea break. Can we please settle down? Miko, can you help me call if anyone is outside? Come back in, please. All right, so welcome back to the final session for today. Allow me to introduce our presenters. We have Salim Faiki Salim from NMCP Zanzibar. Can we welcome him to the podium? Hey. Then we have Joseph O. Alade, NMCP Liberia. Okay, so let's welcome Salim to take us through the first presentation.
Hello, everyone. Hello, everyone. I know there's somebody who are going to doze off. Don't doze off, please. Even you take a coffee. So, my name is Salim Fak Salim. I'm from Zanzibar. I'm working with Zanzibar Malaria Elimination Program. So I'm very happy to see you. That is my first time to be in Nairobi. But I'm very happy to see all of you. So today I'm going to present about the digitalization of mass replacement campaign in Zanzibar. And this is my presentation outline. I'm going to present the history, core background of mass replacement campaign in Zanzibar, improvement, overview of campaign digitalization, challenge, lesson learned, and a recommendation for the future digitalization in the similar campaign. For historical Zanzibar, we have already conducted the 6th round of mass replacement campaign. Formal, the ITN mass campaign in Zanzibar was conducted traditional. But this time, household registration is one among the important components of the campaign. Micro-quantification and the ITN issuance were done manual through tough, I can say tough, paper-based system. After registration, our campaign were involved in two main components. So we were having the registration and the issuance. So after registration, the beneficiary, head of household, were given the fiscal card that prove eligibility for ITN collection during issuance phase. And sometimes, if you are lost the coupon number, fiscal card, you cannot get the ITN. If you get ITN, you're supposed to get the struggle. So it was tough. So if it was implemented through traditional, tough, manual, so we were faced with the main challenge. Some of challenge is manual error due to paper-based system during registration and issuance of ITN, but also delaying of data entry. As we know, transition of data from paper to digital format was lead time wastage and sometimes campaign delay. Tracking of the real time was unavailable. So if it is unavailable, we were not conduct the monitoring. Also, we are not conduct the decision making. Also, losing of record. As we know, hard copy can easily misplaced and sometimes can easily damage. Even you ask me about the a record of the previous campaign, I cannot give you because it was, as I said, it was very tough. But also cheating. Sometimes the head of household can change the coupon number or fiscal card that is what eligible to receive the ITN. Can change number 1, can change number 2, 2 can change number 8, and so on. So, a campaign of 2024 digitalization totally transformed from manual household registration to electronic use smartphone device, whereby total number of 1,110 RA, registered assistants, were tended to cover 2,100 distribution points. So we were having the mass ITN app dashboard that giving out the real-time track to count the automatic number of household registered and the ITN issued, and also give out analysis about the inter-campaign and finally produce the numerical report. Quantification also was done automatically rather than manual. really, ITN digital campaign was accurate, efficient, and real time. So, Android smartphone and the Mass ITN app downloaded from Play Store was taken as a main digital tools. Also full utilized in all during the campaign. Server data management system also are used to store registration and issuance of household data. Open Data Kit was unable because the Zanzibar we were suffered, till now we suffered from the poor internet connectivity. So we recommend a developer to have the Open Data Kit in our campaign. So Open Data Kit were unable to collect the registration data offline, but sync when connected to the internet. So we were having the SMS-based MRC that was designated to remind household on the upcoming of the campaign to be registered, also to collect the ITN during issuance dates. Also e-commerce, mobile money such as Tigo in Zanzibar were used for incentive payment to field work. So thank you for good collaboration, strong collaboration. We thanks for bringing together expertise, funding, logistics and technology. Thank you, Minister of Health Zanzibar, as among the partnership leading campaign planning. Thank you, GF, PMI, USAID for funding support and ITN procurement. Thank you, A2Z, Simba Logistics for producing and supply ATN. We were having the PARS, Digital Square, and for assistance and the digital innovation. We were having telecom campaigns such as Tigo and Azantel for supporting mobile transaction and SMS reminder to the household about digitalization campaign. Also, without forget the Black-Through and the CHW were very important in mobilization and giving out education about the ITN access and the utilization. So for improvement of campaign planning and implementation due to digitalization, we think we have improved the coverage accuracy. Before mass replacement campaign 2024 in Zanzibar, our coverage was below 80%. So, but on mass replacement campaign 2024, our coverage was 99.09. So also we improve accurate tracking of ITN distribution through the digitalization campaign. For all previous, we experienced for all previous mass campaign, the real time track was unavailable. Also, the campaign was minimized frauds and the duplication of ITN allocation. Also, improve the community participation and engagement. Without forget, improve the human related competence to use innovation, since we trained RIA means registered assistants that use the smartphone and the application software to register and issue ITN. So if we compare the non-digitalized mass campaign and digitalized campaign of 2024 in Zanzibar, we can see that for the all previous campaign, the coverage, as I said, was below the 8%. But with thanks God, the coverage of digitalized mass campaign for first time, full digitalization of ITN campaign in Zanzibar, we have succeeded to get 99.09%. Real-time tracking was unavailable for digitalized campaign, but it was not available for all previous non-digitalization campaign. So we were having the digitalized campaign, which used the SMS and some Instagram clips to enhance ITN utilization rate in some extent. For but Zanzibar, as we know, for the previous non-digitalized campaign, there was, we can say, the community meeting and IPC. If you want to mobilize a society before the digitalization campaign, you're supposed to go to the community, just to tell how you are supposed to conduct the interpersonal communication meeting, just to tell them how to use, how to utilize, how to access, where to get the ITN. But now, just we send an SMS. Hey, you are supposed to sleep under mosquito net. You're supposed to go somewhere just to collect your ITN. Also, results from digitalized campaign are available on the Mass ITN software, while previous non-campaign, they are recorded on the paper, and some has been misplaced and damaged. So these are key achievements resulting from digitalization. A total of 2,900,203 household has been registered out of target 2,800,793 registered to receive ITN. Moreover, a total of 1,578,562 people were registered during the campaign to receive ITN. At the end of campaign, we have succeeded to get 99.09 of coverage, whereby 857,325 number of ITN has been issued to the registered people. The baseline target was to issue 865,186 equals to 100%. The campaign also was supported with intense during and post-SBC campaign. So monitoring, as I said, we were having the real-time tracks, so we were succeeded to conduct monitoring about the ITN issuing on real time through Mass ITN dashboard, and a physical visit to all campaign area to fix the some problem arose. And this is the number of ITN issued in 314 here during mass replacement campaign, April 2024. If you look roughly on a per coverage of ITN issued, you can see there is no any district which have below 95% of coverage. So I think we done well. So how the Mass ITN 2024 dashboard look like? It is look like that. So you can see the number of district. You can see some SBCs component report, teams campaign, and others. So even we are very happy to get the 99.09 percentage of coverage, but also the digitalization were having the challenge. So some challenge faced during digitalization implementation, poor internet connectivity for some remote area. Also data accuracy and integrity. So there are some, sometimes there was occurrence of multiple record and incomplete information during registration. Inadequate digital literacy. So as you know, we were trained more than 1,000 registered assistants. So some registered assistants were not familiar to mobile application and digital tools. Even we train them. Also limited server space, which are leading the slow flow of the registration data. The mobile app sometimes could not pick the same coupon for unknown reason. How they were overcome. Even we were having faced with the challenge, but we were overcome through the system. We recommend the system developer that has been updated app to work offline app and sync data when connected to the internet. Formal, the app was not collect the registration data. So we recommend them to update app in order to work offline and sync data when connected to the internet for some remote area where the internet connectivity is poor. Also, supervision and monitoring has been conducted to fix all mistakes arose through the real-time tracks. Data clearance before issuance has been conducted by ITN officer and system developer to fix the some multiple registration arised. System developer, as I said, there was a low server space as a challenge, so the system developer upgraded the server space from the 80 core. The former the core was 8, but there we recommend them to upgrade from 80 core to 12 core. Key lesson learning from digitalization. We have the main lesson to learn. The digitalization we know of campaign provided program management in real times. Also, digital record always ensure highest ITN coverage due to availability of the real-time dashboard. Enhance the strong collaboration and the community mobilization is very important, and the regular reminder of digital SMS were very important to remind them on upcoming of campaign. Improved data accurate means digitalization always reduce, as we know, error in all registration and the distribution record. Digital platform always ensure ITN reach to right and targeted household. The former, this was among the challenge, but now through the digital platform, we ensure that ITN reach to the right and targeted household. Digital platform also implementation of MRC takes short time compared to traditional due to elimination of many manual error. And for information, Zanzibar will take 3 weeks to complete the campaign of 2024. Only 3 weeks. And we believe that this was enhanced by the digitalization of campaign. We recommend that the stronger collaboration between the government, donor, and communication is very important. And we believe ourselves that we got that coverage because of the stronger collaboration between government, donor, and the community leader. We know and we experience a lot of campaign that forget about the community leader. You are going to community, and you are forget about the community. You cannot succeed. You cannot get good coverage. You are supposed to have the good collaboration. Also, if possible, the uses of fingerprint during registration, we believe that can minimize the multiple registration, because the multiple registration, this was among the one challenge that we faced during the implementation. So if it is possible, we must use the fingerprint during registration to minimize this multiple registration. App should be work offline. We recommend us during data collection and sync data when connected to the internet, since some people live outside of the city and we experience their poor internet connectivity. Provide real-time campaign progress for public and stakeholder accountability. Introduction of geospatial mapping to track the distribution and the issuance coverage. The last, community engagement through digital advocacy such as SMS through their phone on the progress of campaign is very important, and it must be considering. Thank you very much for IFRC for sponsorship. Thank you for attentive listening. Karibu Zanzibar.
Okay, thank you, Zanzibar. I will now call on Mr. Joseph. We'll take all questions at the end of the 2 presentations. This is, yeah?
Okay, so let me begin by saying good afternoon. I know we are all tired after almost 5 days, and thankfully AMP decided that my presentation be the last. So to tell you, it is very short. You know, I remember 2 years ago, I was in Nairobi to attend the AMP annual meeting, and I was just here listening to people's experience with digitalization. Today, I'm happy that I am also about to share Liberia's own experience with digitalization. So it is a pleasure to be here. Okay, so I'm Alade Joseph. I'm from Liberia. So you see the outline is very short. So I'm just going to, for those of us that don't know my country, you would know my country today. You also talk about the malaria profile. We give you the background and we give you the substance, why we decided to go digital. Okay, so on the right, if you are from where I stand, on the left is my country, Liberia. Everything you need to know about Liberia is there. On my right is the malaria situation of Liberia, and everything you need to know about the malaria situation of my country, you find it there. On the right, I just want to tell you we've made progress since 2009 with the distribution of nets, and you look at our outcome indicators, we've made progress in both ownership, access, and use. Now, just a brief background. I'm not going to bother you with the disadvantages of paper-based because everybody said it today. Unfortunately, there's something I'm going to do that nobody did. It's like everybody now see paper-based has been so bad. But for me, I want to be the first person to say thank you to paper-based. Because at least we started from somewhere, it took us from somewhere. It made us to realize some of the things we needed to improve. Then we decided to go to digital. Now, what we decided to do is to just summarize the entire problems that people listed today about paper-based into one slide. And that slide is getting reliable information on a campaign. So if you look at the slide there, you see the campaign manager, instead of knowing what is happening in the campaign, he's asking somebody. That manager has a meeting with his boss, few hours, and he's calling somebody to ask them, what have you done? What is the information about the campaign? That person too, unfortunately, does not have the information on hand. She is telling her boss, let me call my data manager. It is possible that data manager too will have to rely on the information from the supervisors on the field. So for us, that was the challenge. That was what we wanted to fix. That was why we went to digital. Now, our partner, our digital transformation partner was and is eGov. And for our 2024 campaign, we digitalized the 2024 campaign. We've had series of campaigns. We have campaign 2015, 2018, 2021. Paper-based took us through. 2024, we went digital. So what did we digitalize? We digitalized the major components of the campaign. HHR, or household registration, supply chain, distribution, monitoring, evaluation, and training attendance. Now, before that I move to the next slide, let me tell you, it was not a one-time snapshot. It took us a great deal of discussion, in-person meetings, virtual meetings. I remember ECOF even had to fly to Liberia, and we had a one-week meeting at a point where there were heated tussle. And I remember one of the ECOF representatives said, but then you are not fair to us, because we were demanding, we were asking for so many things. But one good thing they told us is, what do you want to fix? Now, digitalization, according to that lady, is not because you want something nice. It's because you want to fix something. So tell us what you want to fix. So what we wanted to fix drove all of the discussions. The in-person meetings, the digital meetings, what we wanted to fix drove those meetings. Now, what we wanted to fix, they are in this one slide. We wanted reliable, near to real time, visible data. We did not want campaign manager asking somebody for campaign information. So if you look at the upper part of this slide, you see a household registrant registering a household using phones. Remember we said now we call our application Liberia Health Campaign Management Tool, which has been powered by Digit. So the phones were pre-installed with the application, and I'm not going to bother you with training because we did extensive training. Now, you are seeing a registrant registering a household. Using the phone, we had vouchers with pre-generated QR codes. So as a household was registered, using the phone, the household information was also written on the voucher. At the end of that, the voucher was scanned, and the QR code was linked to that household. After that, the voucher was given to the household. Now, once that registration was done, the application was both online and offline. So right there, as you do your final data collection, you submit, the data goes straight to the cloud. And we have visible means of seeing our data. You see the dashboard in the middle. And the dashboard gave us visibility at the very lower end of the campaign. In Liberia, all of our health intervention is at health facility, community level. So on the dashboard, using the dashboard, we could view data at national, at county, at district, at health facility, and at community level. So we had people with access at all of those levels. So no one was telling you what your progress was. You knew just by looking at the dashboard. If you want to look at the dashboard every hour, every 30 minutes, you know exactly what is happening, where data is coming from. You know all of the teams, who is working, why Alade is working, and we are not seeing Alade data. It gives you reason to ask. Now, with the syncing of the data, we also see the geo points. The good thing is the system was also built to capture geo coordinates. So as the data hits the server, we have a JSON map with all of our geospatial information. and we had the data points hitting the JSON maps. The second picture you are seeing there is a distribution. So during the distribution, all was done was the beneficiaries will come to the distribution point, present their voucher, the voucher is scanned, automatically all of the information pops out. One thing we did not do, we did not tell people during the HHR how many nets we will give you. Because if we had done so, and people knew the maximum nets we were giving out, everybody would have fallen within that range. But the system was configured such that as soon as your data enters, the algorithm automatically calculates the number of nets you are supposed to receive. So as soon as the voucher is scanned for distribution, your name comes out, it tells you how many nets you have to receive, and the net was given to the beneficiary. Immediately, the data is on the dashboard, and everyone at every level was looking at what was happening. On the JSON maps, once the data goes in, that red dot changes to green. So we had the geo points also for distribution. Now, we also remember I said we digitalized stock management, and we introduced what we call bill scanning. So for those of you that were in the technical meetings yesterday where we presented, we share our experience with you. So I'm not going to bother you with this. Fine. So as the result of digitalization, what did we fix? If you remember the first slide you saw with something like this, you saw the campaign manager asking for information. After the digitalization, campaign managers were no more asking for information, but they were asking, why are you not meeting your target? Because we have access to the data from the community level. We knew which health facility catchment area was lagging. We knew which district was making progress, which district were also lagging. So our fundamental problem of real-time availability and visibility of data was solved using the digital platform. Now, if you look, so just to tell you, the supervisor will sit in his office. If you look down, you see the URL for the system. So the supervisor will just click this URL, enter his credential, and he goes through every county, every district. He can even drive down to the community level, and he saw exactly what was happening there. Now, what is the evidence of our digitalization? We have real-time and reliable data. Even as I speak here, anybody who wants to know what happened, all they have to do is to enter the credential, and they have access to the data. You don't need to ask anybody. We have improved accountability a lot. Because I tell you one thing, during the campaign, we knew exactly who were working and who were not working. And we will call a supervisor and say, hey, Alade is assigned to health facility X. 2 days after the campaign, we have not seen anything from Alade. What is he doing? There is a need to check on Alade. Digit gave us that privilege. Now, we have trained staff at both central, county, and district level that can implement health campaign at any time. In fact, for our coming campaign, there are a lot of things, a lot of improvement will take place because we have the structure, we have the manpower, and we know exactly what to do, what to improve. Now, Liberia now owns a digital platform. We call it the Liberia Health Campaign Management Application. And this app can be leveraged upon by other programs. We have already started the discussion with programs that we have a health campaign application. You can come and use it. Now, something is missing from the last slide. For the first time, we can tell you coverage of distribution in Liberia. Though the campaign was done during the peak of the rains, very difficult, but we were able to achieve 88% coverage. We registered over 1.4 million households, and we were able to serve over 1.2 million. We acknowledge that where we wanted to go, we did not get there, but we are confident of what we have done. And the data from the campaign is highly reliable, and this is why we know. And we are using the data, we have started using the data for future planning. What are our next steps? A seamless integration with DHIS2. And this is something I want to say to other countries. DIGIT is not a replacement of DHIS2. Because some of us feel DIGIT wants to replace DHIS2, so there are some hitches in data integration. They are asking too many questions, and they are giving us too many delays. We intend working with eGov to upgrade and improve the system. There are things we did during the last campaign that we want to improve upon. And continuous use of DIGIT. DIGIT is in Liberia to stay, because we have the capacity to run our campaign using the DIGIT platform. Now, at our national level, we had challenges which we call operational challenges. We are addressing them, and we will improve on them for our next campaign. What are our best practices? And I love this slide among all of the slides. We had technical committees set up, and every committee had a role and responsibility in the planning process. We had the Joint Steering Committee, which we call the JTSC, which was the clearinghouse for the campaign. Everything we thought we were doing right, if they had a problem, this committee was there to straighten things up. So coordination was the driving force of our campaign. During the campaign, we had daily coordination meetings, checking on every team, every county, every district, knowing what's happening, telling you what's happening, solving problems. We also had WhatsApp groups. We have WhatsApp group at different levels of the campaign. We have WhatsApp group with the national technical team, with eGov, where anytime we had issue we wanted to resolve, we used the WhatsApp platform. And let me say, eGov was very responsive. There were times I used to wonder, I used to even be guilty and say, 5 hours difference, and I'm still sending these people texts. But believe me, they were responding. We had WhatsApp group at regional level, at county level, and we use the WhatsApp group for immediate action during the campaign. Yes, in every good thing there must be some challenges. Yes, we had challenges. Introducing digital for the first time, and you gave 2 days for training, it wasn't easy. And I tell you, even the 2 days were not used to the maximum, because we used the same 2 days to mobilize resources. We used the 2 days to give information on the campaign, we used the same 2 days for hands-on on the tools. So that was a challenge for us. But how did we mitigate it? We looked among the trainees and we spotted people that we know were smart, that were picking up very fast. We picked them up as team leads. Now, during the registration, something happened which we did not know until doing the distribution. There were few vouchers that were not linked during the distribution, and they were issued to beneficiaries. At the time of distribution, we saw few people coming with vouchers. When the vouchers were scanned, they had match not found. It became a song for the campaign. We had a meeting on that. Our first decision was not to serve those who match not found, but our partners advised that the beneficiaries were not responsible, so we should not deprive them. So what we did, we served them, but we separated those vouchers and we entered them in an Excel sheet because we had to account for the net. Internet connectivity, Africa's problem. What we did, we identified hotspots during the macro planning, and we used those hotspots for data syncing. Because in every campaign, the most important thing is to send the data. You can collect the data, but if the data is not sent, anybody will tell you you are not working. Now, we had a little problem again doing the printing of the vouchers. And that's where we will be very careful next time. Because we were printing over 1 million vouchers, we had few QR codes that were printed on multiple vouchers. And the system was built such that the first person that comes with the voucher, with that code, the person is served. And eGov built a system that during the household registration, those vouchers that had similar codes were put aside. So during the household registration, again, we came across few of those cases. Immediately, we contacted eGov. We said, these names are in the database, but the system is telling us the opposite. When they went to check, they noticed that those QR codes were already used. So to solve the problem, they generated new codes, which we attached to those names, and they did a delivery at the end, the back end of the system. Those are some of the things we hope to improve upon to make sure they don't happen. Now, I'm not going to talk about bill scanning because we talked about it yesterday. It was also a little challenge, especially where we had the net stock in the warehouses, bringing them out to scan, then putting them back in the warehouse was another challenge. What are our recommendations? Continued improvement of Digit. We have to address our own operational challenges as a country. We want eGov to focus on the data migration portion of with DHIS2. We know there are some resistance along the road, but we want to encourage you to keep focused. We want to upgrade our platform to include micro-planning. And we continue to ask that Digit continue to improve the platform to increase the user-friendliness of the platform. We say thank you to all of our partners. We want to single out CRS, who brought the idea to us about digitalization and told us that Liberia, you can do it. Special thank you to the AMP, to Mercy. And I tell you, doing some of the meetings, if we just heard massive voice on the call, we knew that it was going to be tough. So AMP was there, Giovanni, Sandra Mela Akoy, my ambassador to Mozambique. We want to say thank you to EGOV for their patience, their tolerance. Sometimes some of our complaints were as a result of ourselves, but we were complaining to them. We say thank you to the Global Fund. We say thank you for PMR, though they are not here. Let all the speakers who want to give PMR a very big hand clap for the support given Liberia. Thank you very much.
Okay, thank you so much to our two presenters. I like their enthusiastic presentation and congratulate them again for joining the digital bandwagon. Welcome. So we're going to take questions now. If you can put your hand up if you have any questions or comments. Okay, 1, 2, just 2? Okay, we'll start with that. 3, all right. Number 1, go ahead, please.
Merci beaucoup pour la parole. C'est un Joelson de Madagascar. En fait, je félicite les équipes pour la présentation. J'ai juste quelques questions donc, par rapport à la présentation de Libéria tout à l'heure. Est-ce que vous pouvez nous décrire un peu ce qu'on entend par la méthode de contrôle de qualité de données que vous avez utilisée pour que les données soient vraiment authentiques? Je ne sais pas si j'ai bien saisi.
Okay, thank you. Number 2.
Yeah, thank you very much. With respect to the team from Zanzibar, there was a mention on the integration with Tigo for payments. So looking at just comparing with what Kenya did in terms of integrating with M-Pesa, so maybe you can be able to clarify the way the payments were, or what informed those payments that were made to the officer or to the healthcare workers who supported in terms of the distribution or the household registration process. Thank you.
Okay, thank you. Number 3.
Thank you for the presentations this afternoon, and this is really a comment from my observations of this afternoon's presentations and this morning's presentations. As a supply chain professional for the last 40 years in the construction, distribution, manufacturing, humanitarian relief, global health areas, I have continually chased this interest in everybody can see what's going on, and for a good reason, and where I've been successful in implementing that and reaching that stage, the enthusiasm has just naturally become more nuanced to a point where consistently the message has become that it's great, Chris, that you know what's happening, but really what I want to know as your supervisor is, how are we doing right now? And I just think it is good to be enthusiastic about knowing what's going on, but it's probably more important to be thinking of the end result. And people have been talking about that, and that's great to see, about being able to be responsive and say, we are confident to tell you that this is what's happening right now, or this is not happening. Thanks.
Thank you for that question. I'll just add mine. For Zanzibar, you mentioned as one of your next steps the use of fingerprint for registration. So from experience, we know that the use of fingerprint is an additional cost because you have to get the device and even the space for the storage of the data that you are collecting. So I don't know if you have taken that into consideration well as your next step. Then I was just curious about Liberia for the bills that you had to unpack and scan. Obviously, it was cumbersome, but I was just curious, was it a large quantity or was it just a few nets? So over to you. I think Zanzibar, you can go first. Yeah.
Thank you very much for your questions. For the someone who asked about the payment, payment is was paid officer or health workers who conducting the campaign. It really, we know everything has been needed to be catalyzed. So there are some amount of there is some budget that was planned for payment of the officer. As we know, there are some officers who are supervised, who conduct supervision and monitoring to see and fix all problem arose. So they were supposed to get the payment. Also, there are some payment who were supposed to get paid for health worker who conducted campaigns. And for the, sorry for the question. Okay, for the question concerned with the fingerprint, that is our recommendations that we given out. If it is possible, we can use the fingerprint, since we see that is the main challenge that we see, that we experience. The main experience challenge was multiple registrations. So if it is possible, but why we ask the question why it is not possible? Even we fear for the budget, for the cost, but why it is not possible while we are in digitalization? That is digitalization. So we're supposed to decide, and as we know, the main objective of mass replacement campaign is just to touch everyone. So I think the fingerprint will be a big solution for the multiple registration, even it is costly. If it is possible, that is recommendation. Thank you.
All your questions, but just to add about the fingerprint, there are some countries that have already explored that. Some of the Red Rose team and CRS are here, so maybe interact with them to understand what were the limitations before you take your decision. Yeah.
Okay, thank you, and I may contact with them how to help us. Thank you.
All right, thank you. Liberia, over to you.
Okay, so for the question on data quality control, we had a very effective mechanism from our end, in country, and at eGov end. So actually especially for household registration and distribution, we were able to pick up duplicate data. We were able to pick up issues where, because with the phones, we know it was challenging, because we had geo coordinates all part of the campaign. So we were able to pull data that we saw the geo coordinates were too close. The proximity of the geo coordinates were very close. Some 2 meters apart of households, some 5 meters apart households. So we pulled all of those data and we did check. We called the counties. We made the counties to call the the registrar to ask, you register Joseph, John, and Peter, the proximity of the QR code is too close. What's happening? For those that could not provide us satisfactory reasons, we have those data. Because one thing we were aware of is you can have more than one household in a structure. So we were very aware of that. But in a case where we saw it overwhelming, it became a concern to us. We acted on those. We have facilities, catchment area, or community where we know they register, for instance, they register 500 households. For distribution, we see more than 500. It told us that people were syncing the data multiple times, or people were scanning one voucher multiple times. We did all that. And it became so severe that the partners we had that were implementing the campaign, some of them even thought we were deliberately hurting them so that they could not meet their targets. Because as they were looking on the server, they were seeing good numbers. But when we went on the server and did a cleaning and they saw their percentages drop, they had issue with it, but we told them that you had duplicate data on the server and there's no way we can report duplicate data. Because, especially for me, I was concerned that the Global Fund may do quality check on the system. So we were very much aware of that and we took all of those precautions. Now it is possible you can catch all of the rogues. Maybe one or two rogues slip through the crack, but we made sure that our data quality check was effective. So now if you go on the server and you download the data, I can assure you, you will not find duplicate data on the server. You will not find, and the duplicate data will be identified by the QR code. Because the names may be the same, but you will not find one QR code on the system more than one time. Then to your second, to Fatih, concerned about the bill scanning. It wasn't one bill, it wasn't two bills. You go to a district warehouse where they receive 200 bills already stuck. Maybe we were not too helpful to the warehouse supervisors, especially Alade, because we insisted that they must scan the bills. So they had to take all of those nets out. And the good thing what some of them did that I appreciated was they stacked the bills with the barcode all facing out. So those that fell in that category were easy for them to scan. But you that had a barcode all scattered in stacking, you were forced to bring it out. And you scan it. And we made it, though it was not their fault, but we made them to do it. Thank you.
All right, thank you very much. Are there any other questions? No? All right, since we're finishing, oh, okay, quick one. I think if you can assist him, please.
Ok, merci beaucoup aux présentateurs pour la qualité des présentations. J'ai une question à l'endroit du Libéria qui a utilisé l'application Digit. Comment vous avez pu gérer le paiement des acteurs, notamment pendant les opérations de dénombrement à la fin de la campagne? Est-ce que vous avez eu des soucis? Sinon, comment vous avez pu gérer tous les acteurs qui ont travaillé pendant la campagne? Merci beaucoup.
Yeah, actually at the planning stage of the campaign, our intention was to do the payment through Digit. But we already have digital platforms in country, mobile digital platform. So just to let you know, NMCP did not pay, because we were not in charge of the resources. The PRO was in charge of the resources, but health personnel were paid through what we call mobile money. So, like I said, we digitalized the attendance. So, based on the attendance, the names were submitted to the PRO, that is the principal recipient for the Global Fund, and the personnel were paid through mobile money. In fact, Global Fund has a strict mandate of non-cash policy. So you don't take money and give to somebody. So we use the national digital platform, that is a mobile money platform for payment. I hope I answer your question. Thank you.
Yes, thank you very much. Let's appreciate our two presenters. Thank you. Go back to your seats. Okay, on that note, it's 5 p.m. I think this is a good place to round it up. I'll hand over to Robert to close us for this session. Thank you very much.
Let's appreciate all the presenters today very well. Let's appreciate them again. I think they fought down well. And I think we can appreciate ourselves as well. We've stayed very much awake and very much alert throughout the sessions. Can you take me to the slide before this? So, yes, so for tomorrow's session, you have some preliminary session in the morning, and then in the afternoon, we are dedicating it to looking at some topics that we want to discuss in the form of a working session. The topics we have, there are 4 of them. The first topic is the use of bring your own device, where we ask community health workers or the volunteers to use their own phones for campaigns. So we have a session that will look at some of the key issues. I think we had a lot of questions on that earlier today, so we discussed some of the key issues. Then we have integrated campaigns and cross-program digitalization, looking at how we can actually achieve integration of various campaign digitalization, reuse of data, among others. The other session would specifically look at some of the presentations today, data use, data reuse. Can we use our data or registration data for a campaign? For the next campaign that we are going to do, how can we better explore using that data, using the data maybe for other interventions as well. And then the second session, which will be led by WHO payment session, will look at how we can digitalize our payment. And I think we've had a lot of discussions around that as well today, how we can digitalize our payment flow to ensure that we are not having delays. I think one of the observations we have seen, especially with digitalization, if you don't pay the workers where they hold on to the devices, pay me before you receive your device. So it's important that we ensure that we are also streamlining that process to ensure we are able to pay workers efficiently. So you have QR codes. Go to the next slide. On your desk and also on the slide, please kindly, we did that in the afternoon. Only about 50 people had selected. Please, I want us to do it. We have QR codes on the desk. Each desk have a QR code there. Kindly scan it and select the session so we know which rooms will be allocated for tomorrow's afternoon session. Last few announcement. Tomorrow we are having the meeting on the 4th floor, RMRC 1, which is the 4th floor, where we had discussions yesterday. So tomorrow we are not coming here. We will be on the 4th floor. Our cocktail, which is from 6 to 8 p.m. 6 to 8 p.m. Our happiest hour, as Jason said. So happiest hour to take place from 6 to 8 p.m. Unfortunately, due to the weather, we are not having it at the open grounds or where we had it on Monday. We are going to the room where we have the meeting tomorrow. So at least it's a good opportunity for those who would not or who did not know the room to see it, so that tomorrow when you come, you go there right away. So it will be on the 4th floor. On the 4th floor, Amasi, the room name is called Amasi. Amasi 1 and 2, and also just at the area where we had the coffee. So at 6, we are expecting all of us there to have our happiest hour. So on this note, thank you very much for participating, and hopefully we see ourselves over there and also tomorrow.